May I have your attention, ladies and gentlemen? In the name of Allah, the most beneficent and the most merciful. Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, Assalamu alaikum. I, Dr. Afshan Javed, welcome you all on this auspicious occasion of 5th Liaquat University of Medical and Health Sciences JAMSHORO International Dental Conference 2022 in collaboration with Pakistan Prosthodontic Association. We are really thankful to all the national and international galaxy of iconic, prominent, and well-known professors who have come here a long way to grace this auspicious occasion. We also welcome to all the invitees, postgraduates, undergraduate students, and the distinguished guests and audience from all over the country. Ladies and gentlemen, we have to prepare our future dentist generation. This is our national duty to make our young budding dentists to fully equip them with up-to-date knowledge so that they're able to compete with the ever-changing world. Conferences, seminars, and workshops are quite stimulating and encouraging to explore new horizons of up-to-date knowledge. It is in this pursuit that Institute of Dentistry LUMHS has always strived hard for the achievement of the state of art in every discipline of dentistry and patient care. To begin with this spacious occasion, let us pray to seek ability from Allah. My Lord, grant us the power and the ability that we may be grateful for your favors which you bestowed on us and on our parents, and that we may do righteous good deed that will please you and admit us by your mercy among your righteous slaves. Amen. For further proceeding of the session, I would request Ms. Saira and Mr. Nabil to please come to the dais.
Bismillah ar-Rahman ar-Rahim. Starting with the greatest name of Allah, who is the most beneficent and the most merciful. Dear distinguished guests, honorable invitees, ladies and gentlemen, Assalamu alaikum, and a very good morning to all of you. Myself, Muhammad Nabil Khan.
And I am Saira Shaukat from second year BDS.
It gives us immense pleasure to welcome you all at the 5th LUMHS and 9th PPA International Dental Conference 2022, organized by the Faculty of Dentistry, Liaquat University of Medical and Health Sciences JAMSHORO, in collaboration with the Pakistan Prosthodontics Association.
Let us start the session with the glorious name of Allah Almighty. For recitation of Holy Quran, I would like to invite Mr. Rais Ahmed.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألم نشرح لك صدرك ووضعنا عنك وزرك الذي أنقض ظهرك ورفعنا لك ذكرك مع العسر يسرا إن مع العسر يسرا فإذا فرغت فانصب وإلى ربك فارغب آمنت بالله وصدق الله العلي العظيم.
Jazakallah. We would now call the panel of experts of scientific session. So I would like to invite Professor Atif Jawad. He is the HOD and Professor of Prosthodontics, Bitai Dental and Medical College, Mirpurkhas.
Dr. Parmanand Das, he is Principal of Pitai Medical and Dental College, Mirpur Khas.
Professor Afif Umar Zia, he is a Professor and Head Department of Orthodontics, Margla Institute of Health Sciences, Islamabad.
We would now proceed to our first lecture of today's scientific program. To deliver today's first lecture on silicone as an alternative to acrylic as a denture-based material, I would like to invite Professor Asif Ali Shah. He is Principal, Rashid Latif Dental College, Lahore.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ربنا وجعلنا مسلمين لك ومن ذريتنا أمة مسلمة إنك وأرنا مناسكنا وتب علينا إنك أنت التواب الرحيم ए रब हमारे और कर हमें तेरे हजूर गर्दन रखने वाला और हमारी औलाद में से एक उम्मत तेरी फर्मा बरदार और हमारी इबादत के कायदे बता और हम पर अपनी रहमत के साथ रजू फरमा बेशक तू ही बहुत तौबा कबूल करने वाला मेहरबान रब्बना वबअस फ़ीहिम रसूलन मिनहुम यतलू अलैहिम आयातिका व युअल्लिमुहुल किताब वल हिकमा व युज़क्कीहुम इन्नका अंतल अज़ीज़ुल हकीम। ए रब हमारे और भेज इनमें एक रसूल इन्हीं में से कि इन पर तेरी आयतें तलावत फरमाए और इन्हें तेरी किताब और पुख्ता इल्म सिखाए और इन्हें खूब सुथरा फरमावे बेशक तू ही है गालिब हिकमत वाला। कुल इन कुंतुम तुहिब्बून अल्लाह फत्तबिऊनी युहिब्बुकुमुल्लाह व यग़फिर लकुम ज़ुनूबकुम वल्लाहु गफ़ूरुर रहीम। ए महबूब तुम फरमा दो कि लोगो अगर तुम अल्लाह को दोस्त रखते हो तो मेरे फर्मा बरदार हो जाओ, अल्लाह तुम्हारे दोस्त रखेगा और तुम्हारे गुनाह बख्श देगा और अल्लाह बख्शने वाला मेहरबान है। I am very humbled to start this Pakistan Prosthodontic Association second day of the conference, which is really miraculously and immaculately done by a Pakistan Prosthodontic Association President Dr. Amir and his team, They have organized it in very nice fashion, and I must adore the students of Hyderabad, Liaquat University of Medical Sciences, that they have participated very enthusiastically and very nicely in the last day, and they have really enjoyed a beautiful music night last night. Today, basically, what I am planning to give you little food of thought, that in future, what I think, there is going to be a change in most commonly used material, which is acrylic, and that should be and may be replaced by the silicon's denture basis. The most common thing which you may have seen, that these from second year, the first exercise you people do in the, how many people from second year are here? Most of you are from final year? So most commonly the first thing which you people were making were these two metal clasps, dentures. This is the first thing when you enter into a dentistry you have been taught. And though I have listened, and I will listen today as well, the lot of implants, but believe me, prosthodontic principles remain the same. The positioning of teeth, because as yesterday Madam Nazia has pointed it out, that the teeth have been replaced and metallic implants are only the source of their anchorage. They are going to anchor it, and the famous example that enter the bolus, exit the balance is not going to happen. But we should know the conventional prosthesis, as you people understand, in your outdoor Liaquat University of Medical Sciences, the patients come to you, the 90% times you have to give them the removable prosthesis. And for the patients, because they cannot afford those expensive treatments, but you should be able to give them more aesthetic, pleasing and long-lasting, comfortable treatment plans. So that's why I think that from acrylic to the silicone is the transfer which is going to happen in the next years to come. For that purpose, if we go historically, there was the prosthesis, those were made in 1500 centuries by the wood. Why we were, and the problems, those were historically there, they are still there, and we are trying to improve them. So why we discontinue the wood? Because it cracked in moisture and it was not aesthetically pleasing, and it was unhygienic and degradation in the mouth. So this was the problem. So then what happened? The science has introduced another material which was a bone, and again the advantages was because of its availability, and again the point which I have pointed out, reasonable cost. Because you cannot sell the things at a mass level which people cannot buy. Then aesthetic and hygienic concerns were not fulfilled. So what happened? Then in 1700 centuries, we introduced the porcelain. The advantages, still we used a lot of porcelain in the fixed partial dentures, and lot of things which we came across, that there was less porosity and low solubility. But drawbacks were also there, brittleness and difficulty in grinding and polishing. Then the few days ago, a patient came to me whose age is 110 years and was wearing a vulcanite dentures made 45 years ago, the complete dentures. So many of you may have seen it only in the books, and but I have seen, I am a very young graduate. I only entered in BDS in 1979, and at that time still we can see the patients, those were wearing vulcanite dentures, and you have to treat them. Then in the era, different materials tried, and the era came of the polymethyl methacrylate, the acrylics. It has got a stable color corresponding to the gums, inert and translucent, reasonably cost and easy to repair. And still we are using this from 1950s to onward. Still it is the most popular thing. Though you can make the dentures in the metal, cobalt chromium alloy, but the teeth part that is made with the acrylic. But same thing can be replaced now with the plastics and the silicone materials. You can make the metal denture base, which is not really required in the silicone denture bases, because that is going to create increasingly very nice weight loss. When you are going to make a silicone dentures, they are going to be extremely lightweight and aesthetically very, very pleasing. And you will be able to see right now that you cannot find out where the teeth are, artificial teeth are. So that is, the change is going to come, in my opinion, in future. These are the different materials. Those are available today in Japan. These generic names, polyamides, and the product names, and the manufacturers, and most of the things which you are able to find in your literature. So now this is the shift which I am talking about, and this is the different positions where you have replaced, say, simple single unit tooth, so where the patient cannot afford the dental implants, and the fixed partial denture. Really, even today, after working for more than 38 years in private practice and in government hospitals and now in private hospital, grinding the adjacent healthy teeth is really very disturbing for me. So still patients where I work nowadays, every patient, this is a normality, every patient wants fixed prosthesis. So now I am giving them, if they want fixed prosthesis, resin bonded bridges, not the teeth supported, fully anchored bridges. So if we cannot give implants. But this is the very nice, aesthetically pleasing option of a removable prosthesis. Instead of acrylic, you can use silicone. And same here in the posterior region, the premolars. But you can provide, this is a very difficult proposition when you have got the free and saddle areas, very challenging. You can find out that there is no clasp, there is patient when comes here, it's so pleasing that there is no occlusal rest, because I will tell you later on that why we can provide such type of dentures. These are extremely resorbed, grossly carious teeth and ridges, so they are mutually, they are very difficult as far as the retention and the support and stability as far as the partial dentures are concerned, but that matter is very nicely solved by, because you can take the retention from the tissue as well as from the teeth, and without giving any disadvantage of aesthetics. Again, you can see another case where aesthetically pleasing, where lot of teeth are missing. You see, the last time it was even you want to replace these teeth, and that's what in our, yesterday we were talking about, that the patients have got different phases. A patient does not become edentulous very easily, very quickly. There is a transitional phase where we are going to loss over all the teeth because of the periodontal problems and because of the caries regions. So you have to give an interim treatment plan. And that interim period is very important for the patient's comfort. And patient should be very comfortable, and patient may be able to adapt with these processes if you have given them in this period. So these are the alternatives of acrylics, where we can provide a stable, fixed, removable prostheses which are lightweight and easy for the patients to adapt with. Same here, another case in the premolars and the molars are missing. Here you can find out if when you are going to give the fixed prosthesis, there is a very long span bridge. So it can be, and again, whatever you are going to do, you are going to end up in a free and saddle area if these teeth are lost. But you can keep them for a very long period of time if you are going to give them removable prosthesis, especially with aesthetic pleasing and the comfort is there. The lower interior teeth, when they are going to have a periodontal problems, very commonly you are going to find out these teeth are there. So these can be easily replaced with a lot of no aesthetic compromise. Now with this, I will like to go into a detail where I would like to put my point by the literature review that why I think the silicons, the plastics, are going to replace the scientifically from the acrylic. Do I have 5 to 10 minutes? Okay, thank you very much. Limitations of functional and unaesthetic show of metal acrylic removable partial dentures. This necessitated a fundamental shift in the design and manufacture of removable partial dentures, resulting in the introduction of alternative denture-based material such as thermoplastic resins. Nylon polyamides were first synthesized in 1950s, and I have visited this laboratory in New York when I attended the Greater New York Conference in 2005. Then I took the course of the Valplast denture-based material, and I bought that whole system at that time, and I was the trained Valplast technician at that time in 2005. And I have learned this, how to make these nylon dentures, and they are a little bit different from acrylics, because at that time I found out first time that injection mold, now acrylics are also coming in injection molding system, that the silicone dentures, they are injection molding systems, and they have got a very big advantage over other systems of acrylic and metals. Nylon is increasingly widely utilized nowadays, and elastomeric resins can be mixed into resin polymer formula to increase flexibility. So they are extremely flexible, and that is why that free and saddle area denture bases, the mucocompressibility of the free and saddle area and the teeth is different, and that's why you need to have a functional impressions, and that's why you need to have altered cast technique. And by passing all these, you can use material that can compress into the it can create a stress breaker effect, and that's why we have introduced this material. This is the material which is called nylon denture-based materials, and there are different types of nylon denture-based materials. Nowadays, in the dent supply company, क्या हुआ? The manufacturers of acetyl polyaxyl methylene began in 1960s, so is used for dental purposes as non-brittle resin in year 1970. Thermoplastic acetyl is a homopolymer and has short-term good mechanical properties. It resists wear and fracturing and well suited for maintaining vertical dimension. The stability of polyaxyl oxymethylene dentures is comparable with the stability of removable cast partial dentures due to their high precision and minimal discrepancy. Acetyl lacks the translucency and aesthetic appearance when compared with the polycarbonates. The polyesters are also elastic and biocompatible. They are transparent and easy to polish.
Sir, 2 minutes.
Ji, thank you. So, then following changes in chemical composition, thermoplastic materials are now appropriate for manufacturing removable partial dentures that completely or partially eliminate the metallic components. So, nylon's key advantage is its superior mechanical resistance to shock and repetitive strain. It is conductive to cyclic load and has increased fatigue resistance. Due to excellent aesthetics, ductility, creep resistance, and fracture resistance, nylon is considered as outstanding material for metal replacement applications. And I would like to show you this case study where this is a school teacher. She cannot afford the implant prosthesis. This is her oral condition. You can see the periodontal problems, the shifting of teeth, and she has got already acrylic partial dentures from somewhere which were not giving her any help. So what we did, of course, extraction of few teeth, and then by trial wax up, showing how we can make the teeth more aesthetically pleasing, the vertical dimension is maintained, and this is clasp-free dentures which we have made for her, and now you can see the smile is really, again, she can, with confidence, she can smile and she can eat very nicely on a transitional phase from the complete dentures, but that transitional phase may last for another 10 years and maybe more. Here you can see that these are the very challenging cases where both anterior and posterior lower teeth are missing and where the natural teeth, opposing teeth are there. So you can see that these aesthetically pleasing dentures where you can find out that there is no compromise in aesthetics. Here you can find out that mutilated dentitions and the vertical dimensions are lost, and you can find out that how to replace them instead of acrylic with the more pleasing appearance of the dentures. Though one only thing for the postgraduate students, as you have seen, the gingivally approaching clasps are more aesthetically pleasing, they are more retentive, and in these silicone dentures, nylon dentures, you can provide gingivally approaching clasps rather than the occlusally approaching clasp. That is going to give you the better results. So again, in the upper dentition, you can find out that these are the challenge in the metal clasps, visibility, that is always an issue, and this has been solved by the silicone dentures. I am not going to go, these are few more cases those have been done by me in recent past, because from last 4 years now, I am only making silicone dentures, and there are 3 laboratories in Lahore. Those are very efficiently doing it. And I did the study I have sent the dentists the questionnaire. This is the questionnaire. I send it to the dentist. Those get the work from these 3 labs. And there were 16 questions. I have sent them, and we were talking about that who decides this, that which type of a denture we want, the patient or you, and we have seen that why you want a flexible denture, and how many the dental surgeons do the metal dentures, acrylic dentures, or the flexible dentures. And the results of those studies, I will just go into that.
Sir, it's time.
बस ये आखिर ख़त्म हो गया results are. The results revealed that only 1 out of 6, where all the facilities they know that in these labs are available and the people those are getting the work from them, only few people got services of the silicone dentures, though their aesthetic advantage and their cost is very compromising as compared to metal and the dentures of implants. So with this, I will say that I will conclude that there will be more stress in my opinion, and there will be more need of making a silicone dentures in future rather than using acrylic. Thank you very much. I am sorry I have bored you so much.
Thank you, sir, for your befitting words.
To deliver today's next lecture on importance of facial aesthetics, I would like to invite Professor Bilal Malik. He is aesthetician CEO, sculpted by Dr. Shiuke, A&E specialist surgeon, Manchester, London.
नहीं कुछ भी नहीं. Assalamu alaikum everyone. It's too much. I've just arrived and I've just landed today in the morning, so I'm sorry I was supposed to be coming here beforehand and got delayed, so I apologize on that behalf. So I landed 4 o'clock in the morning and straightly just come here. Thank you very much for having me here. I was very honored when I was told that I'll be invited to talk to some of the dentists and the doctors regarding facial aesthetics. I do not have anything prepared at the moment. I think there's a workshop later on that I'm going to be training at, but I'm just going to talk a little bit about how aesthetics are really growing at the moment around the world, and it's one of the most fastest growing fields that probably dentists and doctors both can use within their current jobs as well, and also take it as a full-on speciality. That's fine. That's fine. Okay. So my background is accident emergency, basically. I have been working in Manchester area and London area in accident emergency as a specialist. But then I had a special interest in dermatology, which got me interested into aesthetics as well. And eventually I got into aesthetics, and since then I've been a trainer. I made my own company called Sculpted, which operates in London, Manchester, and around the world. Now, to be honest, because I'm going around everywhere to train and running clinics everywhere. So aesthetics itself can be incorporated in various different specialities. Like dermatologists normally tend to think that it's a domain that it belongs to them, but I personally think it can be incorporated with plastic surgeons, dentists, even GPs, depending on what kind of aesthetics you're into. It's not only restricted to the facial aesthetics, it's also body aesthetics as well, body contouring and everything else as well. And it starts from varying degrees. People normally think it's only to do with Botox and fillers, but it's actually way, way more advanced now. Like for example, we are doing IV nutritional therapies, which are also a part of aesthetics. We are doing a lot of weight loss therapies, which are also part of aesthetics. We are doing non-surgical facelifts, which is something much more advanced as well. So there are so many different ways and things that we can incorporate it in our current field. And I was told that most likely I'm going to be having most of the people here as dentists. Am I right? Most of you dentists? All of you dentists? Well, so that's a good one. So normally, dentists normally tend to think, I've come across many dentists who tell me, oh, we can't do anything apart from face because we only know head and neck. But actually, no, you're wrong. You can actually go in, if you go into aesthetics, you can touch other aspects of the aesthetics as well, on other of the areas of the body as well. But yes, you guys tend to like the head and neck area because that's the area that you're the expert of. So for example, non-surgical facelifts are going to be something that you will be amazing at because your anatomy, your knowledge of head and neck would be awesome. So yeah, in that category, if a dermatologist comes and tells you, oh no, it's something we are supposed to do, you're not supposed to do it, that's where you have got an edge. It's nothing to do with the skin. It's not the superficial skin that you're dealing with. You're dealing with deeper structures. You're dealing with the muscles. You're dealing with way more advanced stuff than actually just the skin. So in that aspect, I think it's something that is very, very new and very much, it pays you off. It pays you off in terms of financially as well, but as well as it gives you quite a lot of satisfaction if you can actually create some good results. And when I say, a lot of people, when they hear about aesthetics, they start thinking unnatural, which is not necessarily true, because there's so many things that you can do which can naturally enhance stuff as well. For example, collagen, elastin, enhancing treatments. We do PDO threads. PDO threads is amazing. The results are awesome, actually. They literally reduce the age of the client by years within one session. And there's nothing unnatural about it. That you're actually using sutures, which are absorbable sutures, which are modified with cogs, and that just pulls everything back, and it actually dissolves within the skin within 6 months. So there are so many natural ways of achieving the results or reversing the signs of aging that you can do these days with aesthetics, and that's amazing. Like for example, in my own personal clinic, I hardly use fillers because I don't need to. There's so many other things that will get me the results. So it's all about education of the client, and we as practitioners needing to know what we can do and what's our area of scope. So generally speaking, that's how I started enjoying aesthetics, and that's the reason why I ended up coming up with an idea of a company where we doctors take over instead of a lot of non-medical people who are actually trying to get into this field with the right knowledge. That's why I got involved in developing courses for a lot of other doctors and nurses as well, so that we can actually train them to a standard where they can practice safely. Because safety is the #1 paramount thing that you want to have when you go to anybody for any treatment. And especially if somebody is coming as a private patient who can pay a lot and who is very conscious about their looks, then you don't want to mess it up, because that would not end up in a very, very good way. You can get sued. So that was the reason why I got into it. And then I actually realized that it's something that can be explored and expanded to a different level. For example, can we keep it interactive? If somebody wants to talk, please raise the hand up and we can talk a bit as well. So, like for example, I'll just give you an example. Has anybody used PRP as dentists? Platelet-rich plasma? Yeah, yeah, so I can see some nods. So for example, platelet-rich plasma therapy can be used for so many of the aesthetic procedures as well, and it's very underrated actually, but the results are documented, the results of it helping with the healing process of the body. So for example, use it for the face, it will improve the skin dramatically. Use it for as a PRP facial, or we call it a vampire facial. You can use the same PRP for hair growth. So if somebody's losing hair, you can use it on the scalp, and that will help improve the quality of the hair. And that same PRP can even be used, or is being used, as intra-articular injections as well. That's what we do in our clinic as well. So although that's not a part of aesthetics, but yes, the applications are endless. So similarly, anybody practicing aesthetics so far in this room? No, nobody's practicing aesthetics at the moment. Anybody interested in aesthetics? Oh, yeah, I've got a few interested. Okay, yeah, so you're at the right place in terms of the fact that you're all dentists, so you have got the baseline knowledge and the confidence how to approach a client, how to assess the face, how to know what not to do, because what's more important to know is what not to do. And the only way you would know what not to do is by knowing the right anatomy, right function, right physiology of that particular area that you're going to be dealing with. So in that case, I'm pretty sure that if you delve into this course which I'm going to be running today, which is going to be a workshop about Botox, basic Botox, we're going to start with that, and then to be basic fillers. It would be amazing. It will be something that will probably give you a more of an insight how you can see your future within this field. And I would welcome any questions if you have regarding facial aesthetics or body aesthetics. If anybody wants to talk to me about it, want to ask anything, please raise your hand and let me know. Right. So I can do that. I can do that. So first thing is, I was just told that this half an hour is just an introduction. So that's why I did not do it. But if we can have my laptop, we can connect and we can show you some things that we do. Yeah, that'll be lovely. Okay. If you really like me, then you might want me to stay, so don't worry. इसको ना वाईफाई है? इंटरनेट है ना? HDMI कनेक्ट करेंगे और इंटरनेट कनेक्ट करेंगे. So we've got 11 minutes. हो जाएगा वो मैं कर लेता हूँ. आप इसको स्टार्ट होने दें. लेट इट स्टार्ट. आप वो उसको उठा लें, बाकी मैं कर लूँ. हो जाएगा. अभी ऑन हो रहा है ना. स्क्रीन पे लगा दिया मैंने. अब वो कुछ नहीं तो मैं अपने इंस्टाग्राम पे फोन ऑफिस पे Come on. हो रहा है वो मैं उसको क्या कह सकता हूँ जो उसने अपना टाइम तो लेना वो हो जाए तुम्हारे पास कोई वो प्रेजेंटेशन पड़ी हुई थी मैंने सबकी सब भेजी हैं उसको Sufyan has got everything okay cancel I'm happy to do that yeah that'll be lovely yeah sure
Yeah, that's what we say. So we're going to get somebody else to do it?
Can we call in the next speaker, please?
Thank you, sir, for your essential speech.
To deliver today's next lecture on anterior composite restorations, I would like to invite Professor Nasser Salim. He's Professor of Operative Dentistry, Institute of Dentistry, CMH, Lahore Medical College.
Assalamu alaikum, everyone. Well, I'll take these few minutes just to thank Professor Amir Bhatt. Sir, wonderful conference, one of the best that I've been a part of. Yesterday, Dr. Nasram, aap yahan nahi maujud the. One of the best gala nights that I have attended. Aur uske baad se this seems like kind of a downgrade. Thank you, everyone else. The audience who are here on a Saturday morning, you guys are the willing learners. A shout out to Rabel. She's quite a force, and she's been conducting these events so very well for the past day or so. And since I've got a little bit more time, and I would like to use that by saying something about one of my dear friends, Dr. Adnan Aslam. Dr. Adnan Aslam की एक female patient ने एक दफ़ा मुझे बताया इनके बारे में एक शेर कहा कि उनके देखे से जो आ जाती है मुंह पे रौनक वो समझते हैं कि बीमार का हाल अच्छा है. So stay back for his presentation, and I'm quite sure you'll enjoy what's coming your way. I can't see the presentation here. Okay, so conservation is the theme of the day. I'm going to talk about anterior aesthetic solution, but more precisely, the minimalistic approach, doing little or as little as possible and still getting some aesthetic results from what you're doing. Some of the treatment options that we would discuss today would be biologically conservative as well as financially conservative. Well, some of them are going to be only biologically conservative and not so much financially conservative. But that's what we are going to talk about. All of us have taken an oath. You may remember or may not remember that oath that you took on your graduation day. And what that oath said was that the first and the foremost principle of practicing medicine and dentistry is to do no harm. So that is why it is extremely important to know what to do and at times what not to do, where to stop, where to do less, so that you are not putting the patient in a position where probably down the lane you are using too many resources at an early age, which that patient may be requiring at a slightly later age. And for that, I think the best paper that anybody can go back, and it's an old paper from 1996, Alderton paper, and that basically talks about a restorative cycle, and I just want to make it simpler for you and more palatable. What that just talks about is the fact that if I do a filling in an 8-year-old today, which we are doing every day, right? Because of the soft diets, they're having caries in a tooth that erupted at 6 years of age. And I chose to do a more aggressive amalgam restoration. Then that restoration, let me give it 20 years. So at 28 years, if it fails, it's going to be an endo. At 48, if it fails, it's going to be an implant. At 58, 68, if that implant fails, you're not going to be having any bone over there. So when I talk about this particular topic, which is very close to my heart, I think that the remaining tooth structure for all of us is like money in the bank. We are all going to be needing it down the lane, and more importantly, our patient is going to be needing it as we go and do treatments for them. So this is a case in which the patient presented with white spot lesions. They are very common. Some of my orthodontic friends, Dr. Afif is here. A lot of these white spot lesions develop post-orthodontic treatment as well, as early non-cavitated carious lesions. And the kind of aesthetic sense that we have in patients now, this may look very simple to you, but that patient was extremely bothered by this white spot lesion, which is a developmental lesion in this particular case and not a post-orthodontic lesion. And I have done this case, I remember 10 years ago, but had this case came to me about 15 years ago, probably, I would have cut a cavity in this particular tooth and put a composite in it, probably a matching one. But I think that is too aggressive an approach to treat this. And I think what I should do and what I now do is what is known as resin infiltration. So you're all familiar with whatever I'm talking about today. It's not rocket science, it's in the books. It's just to jog your memories and bring you back to some of these techniques that sometimes get left out when we are presenting the treatment options to the patient. Just to explain to my younger colleagues how this resin infiltration works, I think first we need to understand why these white spots appear. So these white spots appear because the subsurface enamel has got some porosities because of some demineralization, and those porosities get filled by air. Air has a different refractive index than the enamel, so when light, it reflects through the tooth, we see a different color, we see a white spot. So if there was a way for me to bring the refractive index of this air-filled cavity to close to enamel, that would be job done, wouldn't it be? So what we do in resin infiltration is, we first put hydrochloric acid, not orthophosphoric, the hydrochloric acid. We put it on top of enamel, 15% hydrochloric acid. What it does is, it takes a layer of top surface enamel in microns. It just takes it off, so it exposes those small little porosities to you. Then you put alcohol, so that alcohol dries any moisture that is present in those porosities, because what I'm going to be putting in is a resin, and resins don't like water, they're hydrophobic. So then you put a layer of resin, and that resin has similar, not exactly the same, but a similar refractive index as enamel. So once you put it there, you cure it, immediately the white spots become less noticeable. I'm not saying it's going to make it go disappear, but from a social distance, it's going to be much less noticeable and something that is acceptable to the patient. It comes in a kit like this, where you've got the etchant. I put the company name here because they are probably the only ones making this DMG from Germany. This is available in Pakistan. A single kit would cost you about 25,000 rupees nowadays. And very easily, if just a 1 or 2 teeth per patient, you can do about 6 patients from a kit. So it is available. It is something that your patients can benefit from. What you need to do is, don't just put the etchant over there, but don't rub it over there. You don't want to mess with the crystalline lattice structure that your enamel has. Dry it, put the resin infiltrant over there, polish the restoration, and you'll have a result that looks something like this. So those white spots become much less noticeable within probably a 5 minutes or 10 minutes treatment time, with you cutting absolutely nothing out of the tooth. Similarly, you can use that in orthodontic cases, post-orthodontic demineralization. And what it does in those demineralized cases is, because resin gets in, so it gives a more stable surface. So when acid comes in to attack those cavities, it repels that. So there's not going to be any caries progression in those particular cases. There's a lot of literature support now in these particular situations. Okay, shifting gears to the next treatment modality. Again, if this case would have come in my training days, I would have probably put some composite veneers or a indirect porcelain veneers or something like that, which is a much aggressive treatment option considering what I can do, which is micro and macro abrasion. Again, the kits are available. It's about 2,500 to 3,000 rupee kit for micro abrasion. For macro abrasion, all you need is Chinese लेंगे तो 60 रुपए की भर है और अच्छी ले लेंगे तो 200-300 रुपए की भर है. So all you need is a red band burr, a yellow band burr, some discs to polish it, and then put some, fluoride paste just to make the surface, caries free for future. So you just put the micro abrasive liquid on top. You use not a brush because this is an acid and brushes have a tendency to splatter it all around. You use a cup in a slow speed handpiece, put moderate pressure. Then you take finishing burrs, you do the macro abrasion, and after you're done with macro abrasion, just put a little bit of sodium fluoride paste. They're easily available everywhere. And once that is done, you'll have a situation where you go from here to here in practically doing nothing. You've not taken a lot out of the two patients' tooth and also not out of his pocket. So that would be a win-win situation for all of us, wouldn't it be? When I compare microabrasion with resin infiltration, just to give you an idea, that resin infiltration takes only 30 to 40 micrometers of enamel, while macro takes about 360 micrometer. We are talking about micrometers. That's like as small as it gets, about 0.3 millimeter or something. I don't know. I'm not really good at maths. If I had been, I would rather have been chosen to be an engineer. Okay, then this may look simpler to you. People come to you with discolorations. Those discolorations are age-related, or in fair-skinned individuals, it's the natural color of the tooth, which was the case in this particular case. And you may think, why is Dr. Nasir telling us about doing bleaching, which looks like it calls out loud that these teeth need to be bleached? Because believe you me, in my lifetime, I've seen teeth crowned, and when those failing crowns were removed, I did not see a single filling in those teeth. So I asked the patient, why did you go for crowns in the first place? And he said, I had yellow teeth, not even fluorosis or amelogenesis imperfecta or something else. He said, I had yellow teeth with aging, and the doctor put crowns on top. So that is why it's important to drill in for everybody's advantage that we need to do vital bleaching. I don't need to go ahead. Just take good pictures. Take pre-op pictures. Take a picture of pre-op with the pre-op shade tab, and then take a post-op picture with a pre-op shade tab. Because patients would sometimes tell you, Dr. Saab, mujhe kam farak pada, zyada farak pada, because bleaching is a very subtle procedure. In some people, it makes a lot of difference. In some people, it makes a very subtle difference. It always makes a difference. So for record purposes, it's always a good idea to do that whenever you are in that situation. Lights, please, I'll just make these 2 points over here in terms of bleaching. Lights are good to make money because it looks fancy when you put bleaching agent on the patient's mouth and then you put a light on top, laser, they have seen it in Hollywood movies. It's easy to get money out of the patient. Lights don't make a difference to any amount of bleaching that is going over there. A simple gel can do that. Lights only work when that particular gel is activated by the light. That's all it does. It over dries the tooth, so on that visit, the tooth looks much lighter. But over a period of time, it will bounce back about half a shade. So maybe if you went to A1, you come back to A1.5 or something. So you need to inform that to your patient as well. And also one thing that is less understood is that vital bleaching means only in-office bleaching. No. In some cases, I will do in-office bleaching, and then I will give them home bleaching. And then I'll have their trays with me, where I was trained in the UK. The trays are not the patient's property because sometimes they overuse those things. So you bring them back to the practice if you can. We can't do that over here, of course. So you can use those trays for a top-up 2.5 to 3 years later. Then you don't need to bring the patient in for in-office bleaching. You can just do a top-up by home bleaching, something that I think is important. Then you can just go ahead and do non-vital bleaching. Sometimes when I was graduating, every tooth that had a root canal had to have a crown. That was the norm. Then I started my postgraduate training, And they said, okay, premolars and molars do the crowns, but not the anteriors. Honestly speaking now, sometimes even the molars don't need crowns. Maybe an onlay, maybe. So anterior teeth in most cases only need internal bleaching if need be, if they are discolored. And that's all the treatment that you need. All you need to do is, if you see the picture on the left and the right, you need to make a GIC base, because you don't want to have an external cervical resorption courtesy the bleaching agent that you're putting inside. So just to save yourself from that trouble, you need to put that plug in. And then again, take the shade tab, take a picture, and then maybe bleach all the teeth up. Okay, moving on. So we have talked about resin infiltration, micro-macro abrasion. We talked about bleaching, both internal and external, and a little bit about when a situation like this arises. Please ask your patient, do you have the fractured segment with you? Oh, that could be so much beneficial for everybody's sake. I'm a decent enough aesthetic dentist. I'll show you some of my fillings that I've done, just a little bit of this presentation left. But if there is a segment made by nature, oh, no way in the world am I going to replicate that. So if you have that scenario, please reattach those fragments back. And I have a follow-up of this patient for about 5 to 6 years now. She comes from Peshawar, and she was referred to me by Dr. Irfanullah, probably a cousin of hers. And now she came back 6 years later, and fracture segment is now, or the tooth stump is now starting to discolor a little, so we need to do something, a veneer, a componeer, a direct composite veneer, or whatever. So an extremely valuable treatment that we can add to our repertoire. Okay. Then you come across, and I'm in the last few slides. I hope I'm doing well with the time. Okay. So I don't want to take even a minute extra. So if you have a situation like this, now you don't have a fractured segment, go ahead and do a composite restoration. I am not going to doubt your intelligence and teach you composite restorations over here. But I do want to talk about the finishing procedures. I think they are underestimating. I think they are underemployed. So please, this is the protocol that I would like to use. This is not the finished restoration. This is the initial restoration. So I would like to build them up a little larger. I would like to build them up a little more on the facial surface so that I have room to play with and I have room to do whatever I want to do. So I start with any yellow band burr, a flame shade burr, preferably, and you start putting in the buccal lobes. You need to understand. The point of putting a composite restoration and then putting burr on top of that is not to make it absolutely flat. In young patients, the adjacent teeth is not flat. Adjacent tooth is not flat. So when light bounces off the adjacent tooth and this tooth, everything is good, but you say, oh, this does not look like it belongs in the same oral cavity. So that's the problem that you're having. So you start with giving some external characteristics. Oh, sorry, I'm going back. Then a very good hack or a trick is take your articulating paper, smudge it on both the teeth. See if you have been able to replicate the rise and fall on the facial surfaces on both the sides or not. They don't have to be exactly the same, but they have to be somewhat similar. Once you have done that, use a silica burr, that's very common burr that you can have. Use some discs. And the most important thing then is use some polishing points and then a polishing paste. And believe you me, the prophy paste that you use to do prophy after you've done the scaling, it's an aluminum oxide based paste. You put it on composite, composite will become dull. You need a diamond particle paste, and they are available everywhere. Chinese, Korean, good companies, everywhere you've got so many pastes available to you which are composite polishing paste. Even these camel hair brushes, goat hair brushes, wheels, felts, there's so many, a plethora of materials out there. In Pakistan, whatever I use is available from Pakistan, and I'm not going to talk about anything that is not available here in the market because there's no point doing that. Okay, so this is what you end up with.
2 minutes left. 2 minutes.
2 minutes is what I take. Okay, so this to this. So you need to bring a character to your restoration. You need to bring the internal and external characterizations to your restoration. So in this particular case, what I did was, I just placed a bevel on the facial, and that was all the preparation that I did, right? I did not have the fracture segment, so I had to do that much. Sometimes you can do away with even that particular thing. So like this patient is a very well-off patient, came to me with spaces and some abraded incisal edges, and I gave him all the options and indirect veneers as well, because that's more financially beneficial to me. But since he was an educated guy, so he said, what about the biological cost? Like, I introduced the term biological cost to him. Of course, that patient is not telling me that. And I told him that a composite restoration, I would not be putting a burr to your tooth. For indirect veneers, I'll be cutting. And those who were in my presentation, this is a window plus incisal edge plus a sliced prep, right? I see the heads nodding, so thank you so much for that. So I did an injection molding technique in this particular case. I love the lab guy that I work with, Bamber Dental Lab, Ilyas Saab. I take his name everywhere. I have no financial concerns with him, but he's a lovely guy. Look at the wax ups, they're beautiful. Then I took a clear putty impression material, okay? A putty that you can see through, that light can pass through, okay? But they're very brittle. So हम पाकिस्तानी हैं, तो कुछ जुगाड़ लगानी होती है, तो उस brittle material के ऊपर हमने ये जो night guard वाली tray नहीं होती है, वो press करा ली, ताकि उसको थोड़ी सी strength मिल जाए. Then all you need to do is etch, bond that tooth, just separate the adjacent teeth or protect them with the help of the plumber's tape. It's very easy, like I think it's few rupees, 100, 200. आजकल की inflation में कोई 300-500 तक पहुंच गई हो शायद. Then you take this special composite available from GC in Pakistan with one of the vendors, Advanced Western. You take the needle inside and you can actually see your material going wherever it is going. So I'll move my needle towards the mesial, distal, frontal. I'll fill the whole thing up, cure it, and when I'm done, oh sorry, it was Shofu, not GC. So I'll have a situation that looks something like this, okay? And that's with minimal polishing, no cutting, absolutely no cutting that was rendered to the teeth. So we've been able to go from here to here, from here to here, and every single aspect need to be photographed or checked to see, are there overhangs, are there anything, any small little things. And I tell people this, the last slide, honestly speaking, I learned so many things from my own pictures, like things that I've done right or wrong, because in that moment you probably are unable to appreciate that. So a lot of people were saying take pictures with the help of mobile camera. No, please, I would be DSLR guy, and a good DSLR equipment costs you around about 400,000 rupees now, but it's worth it. And I would just like to conclude, the take-home message for all of you is when you are seeing patients with similar indications now, please give them some conservative treatment options. They're not difficult to do. You don't require a high degree of skill set to achieve this. As long as you're giving that to the patient and doing it frequently, you'll be able to get better results as well. Thank you so much for your patient listening. Thank you.
Sir, excellent presentation. We still have a few minutes, just a second. Are there any questions by the house? Excellent presentation, excellent ideas. Do we have any question?
Sir. What do you think about the GC tooth mousse plus?
The problem, what we were doing is such a wonderful question, honestly speaking. Before resin infiltration came in, what were we doing? We were giving them fluoride paste or GC tooth mousses. The problem with the fluoride paste and GC tooth mousses are, in your experience, if you have done that enough, those white spot lesions turn brown. So they become very stable against caries, but the discoloration problem remains. So the advantage of resin infiltration over that is, it not only makes that surface more stable, resistant to caries, but also makes them kind of disappear or camouflage. A lovely question, sir.
Is there any question,
postgraduate
please?
student? No, everybody is fine.
डॉक्टर तारिक कहा करते थे जब कोई क्वेश्चन ना हो, तारिक ज़मान साहब अल्लाह जन्नत नसीब करे, या सब कुछ समझ आ गया या कुछ समझ नहीं आया.
Is there a question? Sir, there is another question. And you also owe me a share. You also owe me a share.
Afif has always been great. इसको पैसे मैं बाद में देता हूँ.
अस्सलाम वालेकुम. Sir, कभी-कभी जब discoloration होती है, when there is discoloration, we are supposed to use white opaque material as well. So once I did that, and it starts getting, different than the rest of the teeth. So
Anybody who has done
to mask the discoloration, we are using the first increment as a white opaque, and then incremental technique.
So you talk about dental composites, right?
Yes.
Oh. One of the most difficult situations to manage is doing multi-layer composites. And उसमें भी बेटा आपने अगर कभी किया और उसके ऊपर आपने ट्रांसपेरेंट एनामल देने की कोशिश की हो, तो आप सारी चीज़ें वो जो अंग्रेज़ों की देखते हैं वीडियोस में आपको बड़ी खूबसूरत लगती है. इसीलिए मैंने सिंगल ओपेस्ट्री कॉम्पोजिट से किया है जो लास्ट केस है. एंड इट गिव्स मी गुड रिजल्ट्स. द प्रॉब्लम विद दोज थिंग्स इज अनलेस यू पुट द फाइनल लेयर यू डोंट नो. और उसमें भी कई दफ़ा क्या होता है, आपने डेंटीन थिक लगा दी, ठीक है, अब आपने ऊपर से ट्रांसपेरेंट एनामल लगाया, ठीक है, फिनिश करते करते आप आधी जगह में डेंटीन तक पहुंच गए. इट वुड लुक हिडियस. So it takes a lot of experience before you get to where you get to. And I'll be very honest, I get that right most of the times, but sometimes you feel like pulling your hair out. But it's more practice. That's the best. And some instruments जो कि डेंटीन की लेयर को मिनिमाइज कर देते हैं, मैंने यहाँ देखे हैं. 1400 रुपए की किट पड़ी है जो लाहौर में शायद 14,000 की मिलती है. स्टाइल इटालियानो का रिप ऑफ है. तो उसके अंदर एक इंस्ट्रूमेंट है जो आपको मेक श्योर कर देता है कि आप 1 मिलीमीटर का
कटिंग एज होता है जो. हाँ.
Absolutely. Thank you. Wonderful question, beta.
Thank you, sir.
Thank you, sir.
Is there any other question? Just a second. खत्म हो गए ऐसे?
Sir, the question remains the same. If we use a opaquing material more, wouldn't it be a problem for shade matching to the contralateral tooth?
मुझे फहद मुस्तफ़ा वाली फीलिंग आ रही है. मेरे हाथ में गिफ्ट हैम्पर नहीं है कि बांटूं, तो ऐसे दिल कर रहा भाग भाग के इधर जाऊं और इधर जाऊं. ये मैं आवाज़ तो पहचान ली है, तलहा है.
सर तलहा.
तलहा ही है ना, तलहा
Yes,
मैंने
sir.
पहचान लिया माशाल्लाह. सो तलहा वही जवाब वही है यार. मसला ये है कि बहरहाल जब आप एक यंग दांत कर रहे होंगे और सिर्फ एक कर रहे होंगे तो ये हरकत नहीं कर सकते जो मैंने की है. मैंने 6 दांत किए थे, तो आई कुड यूज़ अ सिंगल ओपेस्ट्री कॉम्पोजिट. If it's a very young tooth, you have to use transparent and dentine and body. And yes, it's a problem. It will take experience before you reach there. What you can do, a tip is कि आप पहले मॉकअप कर लो बगैर कुछ भी किए, एच बॉन्ड किए, उसको बॉन्डिंग लॉट ऑफ एफर्ट. फिर कुछ लोग ये करते हैं कि अपनी कस्टम शेड गाइड बना लेते हैं. नीचे डेंटीन लगाई, ऊपर इनेमल लगाया, 4-5 कॉम्बिनेशन बना के उसके साथ कंपेयर कर लिया. दैट्स द बेस्ट आई कैन डू. थैंक यू.
Thank you, sir.
Thank you, sir, for your befitting words.
To deliver today's next lecture on management of dentofacial deformity, I would like to invite Professor Adnan Aslam. He is Professor, Head and Department of Oral and Maxillofacial Surgery, Margla Institute of Health Sciences, Islamabad.
So I'll just set up the timer. Assalamu alaikum everyone. It's always been a pleasure coming here. This is the 4th time I'm at Hyderabad. I see respected seniors. Ma'am Nazia was our kind and supportive principal when I was training. This was 15 years ago. And she really eased the end of our training, if she remembers that. Sir Asif Shah was there at the Demon Municipal College of Dentistry. Sir Nasir Shah told us and taught us that I had never used later on, how to do kneading on the impression composite materials. I don't know if you remember that, but this is that little tip of kneading the impression composite material. I also see Dr. Nasir Salim, and if I don't make Bhavi jealous, the relationship between him borders on something which kind of touches the unwanted terrain before it just comes forward, and he goes back to Lahore, and I come back to Islamabad. So this is it. I am really thankful to have me here, courtesy Professor Kashif Channar, who is not here. He's conducting a workshop today, and our very dear friend, really a privilege to know him when he was at Margala training, Dr. Abdul Jabbar. So thank you for your hospitality. It's always been there. I also see good names here. So this is something that I would be talking about, something very close to my heart, and this is about the correction of the facial deformity. And I'll just set up the timer. The facial aesthetics can be done in many ways, and it can be done through orthodontics, it can be done through non-surgical facial rejuvenation, and I'm sure that Dr. Saab will be showing his cases in a little while. But to us surgeons, the hardcore surgeons, what we see here, for example, is an example of facial. I don't see the pointer. Do we have a pointer here? Sorry. Okay. So when we think about facial aesthetics through a non-surgical way, we frankly see very little difference. So one of these patients had these are just picked off internet, but she had a filler done somewhere and probably a little Botox somewhere, and you can see that there is very little difference. To us hardcore surgeons, we need to see a large, appalling difference in the pre and post-op appearance of these patients. Below this patient is a patient who was treated with orthodontic camouflage, or an attempt was made to correct what was essentially a class 3 relationship with proclination of the upper teeth and retroclination of the lower teeth. And you can see that the already camouflage phase has further been aesthetically compromised. So this brings us to the topic of today, and this is about the correction of facial deformity and how does orthodontic surgery help in so many ways in correction of facial deformity. Now when we talk about maxillofacial, there are the basic area that we tend to delve in is dental implants and minor oral surgery, and then there's facial trauma and pathology oncology. So obviously we start off with implants and including augmentation, including sinus lifts, and including only bone grafts, and facial trauma, mandibular fractures, mid-face fractures, facial deformity, and squamous cell carcinoma has become so common in Pakistan that there is no other option for oral maxillofacial surgeons not to delve into the practice of oral oncology. It's very difficult to stay away and limit your practice to a non-oncological practice. But what is the topic for today is the correction of facial deformity, and you can see that the facial deformity comes in many forms and ways, and it comes in ये इसके साथ ये कनेक्ट करना पड़ेगा.
पॉइंटर अगर आपको चाहिए तो इसका वो चलेगा.
अच्छा पॉइंटर. So okay. Thank you. So okay. I think it's very bright. So anyway. So it comes in many ways and forms, and you can see here that there is a patient with bird face deformity, and there are quite a few of them, and these are the patients in which you can make a larger difference, because the larger the deformity, the larger difference you are generally able to make. And then patients with asymmetries are also patients in which you can make a larger difference. and patients with severe mandibular protrusion, such as a bird face deformity because of bilateral TMJ ankylosis are one such patients. This is Saira Mohan, and this is about the importance of the skeletal correction for facial aesthetics. Now, there was a poll conducted in early 2000s by the Newsweek magazine, and they thought that probably on the modern parameters of what constitutes facial beauty, she was considered to be the prettiest face in the world, this Saira Mohan. But as you look closely at her, there is a sense of proportion which basically correlates with many of the orthodontic and facial aesthetic norms that underpin this facial soft tissue envelope. You need to realize that there will be an equally good-looking facial skeleton inside, and the concept is that if you are able to correct the facial bones to their correct three-dimensional relationship, the overlying soft tissue drape or the soft tissue envelope will automatically come where they have to and will give a balanced appearance to the patient. Now, in order to affect orthodontic surgery, you have procedures that you tend to do on the maxilla, on the mandible. There are procedures done on the chin. And then there can be ancillary soft tissue procedures like rhytidectomies, facelifts, upper blephs, lower blephs, rhinoplasties. And then finally, for larger deformity, not the two-go procedure for every kind of a deformity. And you obviously can't use this in excess of anything. But for larger deformities where there's a larger movement that is required, you can employ distraction osteogenesis in select cases. Now, the beauty of many orthodontic procedures is that almost all of this is done from within the mouth, so it does not leave any facial scars. So the patient is grossly swollen and blue and black from the surgery for the first few days, but as they settle down, there's complete resolution and there's just no mark which is left on the face. The patient might complain of numbness for a few weeks to a few months, but there is nothing else visible on the face, so it's done from within the mouth. So this is a typical example of Lefort 1 osteotomy, in which you make create a cut in the upper buccal vestibule, and then it really depends on what kind of movement do you have to do. If you have to do a maxillary impaction, if you have to take the maxilla up, there's a case of vertical maxillary excess. You make two cuts, you have to measure them, obviously on a pre-operative evaluation. If you want to bring the nasomaxillary area more forward, you can do a modification by doing a higher Lefort 1 cut anteriorly and then going posteriorly downwards. And then you fracture the whole maxilla, the maxilla deriving its blood supply from the palate. So anyway, then you mobilize the maxilla. If you're able to mobilize the maxilla well, only then you're able to take it where you want to. If you're not able to do adequate mobilization, it will not go where you have to, and then you can fix it. So once it down fractures, you can bring the whole maxilla forward, or you can take it upwards, or you can take it downwards, or you can further split this into 2 or 3 pieces. So for example, if there is a crossbite that needs to be corrected at the same time, or if there's a change in the occlusal plane that you have to do, for example, there's a large open bite for which the anterior maxilla needs to come forward, you can further segmentalize it to 3-piece osteotomies. So people even tend to do 4-piece and 5-piece maxillary osteotomies. We do not want to risk the blood supply, so we try to not go beyond 3 pieces of the maxilla. And then you can obviously fix it, and this allows early mobilization and early return to function in most of these cases. There's another variant of Lefort 1 osteotomy, which is called a SARP, in which you do not fracture the maxilla if there's something which is more than 5 or 6 millimeters of transverse movement that is required. You make all the Lefort 1 cuts without down fracturing it, and you create an additional midline cut, and then you make sure that you mobilize it. Extending, duplicate. Duplicate kar dein. Okay. So in a SARP, which is called surgically assisted rapid palatal expansion, you create all the Lefort 1 cuts but you don't down fracture it, and then you create a midline cut, and then you make sure that you have mobilized it enough. Not too much, but enough, so that once you come back and you put a high risk, it can cause very rapid expansion. Now, one of our cases in which we did this, and then the dear friend, Dr. Feef, was able to align it, and interestingly, the patient never required surgery because he was able to, the maxillary dentation became so large that it was able to envelope the whole of the mandibular dentation, so we didn't need to do any other surgery on this patient. Patients with cleft have small maxillas, which is rife with scar, and you can't do a large movement. So in those cases, what we can possibly do is do distraction, and now we have started to employ intra-arch distraction, in which we leave the soft palate where it is, and we just move the anterior maxilla forward. And we'll see a couple of case examples for this as we go forward. Similarly, mandible, the procedure which is most commonly done to do any mandibular movement in orthodontic surgery is probably the prettiest procedure that has ever been described on the bone from within the mouth by Hugo Obergieser, and it creates so many nice intricate curves from within the mouth that it's just amazing. Anyway, once you have cut this, you're able to slide the mandible forward, take it backwards by removing a little bit of bone, once you do this, you are able to preserve the nerve most of the times. The chances of complete nerve transaction is about 5 to 7%, and in that case, you must do an immediate nerve repair at the same time of surgery. Movements that are very large, or where you have to have a vector which is unfavorable, which is, for example, most of the vertical downdraft movements. If you have to increase the vertical dimension of the mandible, if you have to increase the vertical dimension of the maxilla, or the transverse dimension, you need to use something else which is called distraction osteogenesis. Or if the tissues are compromised, such as cleft patients, so that is distraction osteogenesis. Procedure which is done on the chin is called the genioplasty. You typically create a floor of the mouth, a labial vestibule incision, and then you make cuts. You have your insurance marks so that you do not cause any asymmetry. And typically you have preformed plates with which you can bring it forward to wherever you desire. And now we have started to become a little fancier in genioplasties by, now we can also cause a little narrowing, a little vertical lengthening of the chin. So why would you want to subject the patient to a surgical procedure under general anesthesia that has its own set of morbidity, and when you can do the teeth most of the times even without it, and that is basically for aesthetics, for achievement of function, and for stability. So most of the patients with dentofacial deformity, and I see that there has to be many orthodontic residents here. Are there any orthodontic residents here? So most of the cases of dentofacial deformity, for example, in a class 3 case, the mandibular teeth would already be really retroclined, and the maxillary teeth will already be proclined, trying to compensate for the facial deformity that is already present. If you have to treat this with orthodontics alone, you need to extract the lower premolars, and you further risk root resorption, gum dehiscence, and the result can't be stable because you are exceeding the physiological envelope through which the teeth can move. There's only so much that orthodontic movement can do. So if you employ surgery, the result would become more stable. You will be within the physiological confines, within the physiological envelope, as much as the tooth will allow long term. Now, quickly going on to a few case examples. So this patient is typically, can anybody tell which kind of a patient, which kind of facial deformity is it? Sorry? So is it class 2 or class 3? Class 2. Is it low angle or high angle? Low angle. So this is a low angle deformity. So most of the cases of low angle deformity, you would not need to do any of the chin. But then every patient needs special attention and personalized attention. So in this case, we had to lengthen the chin. If anything that you have to do on the chin, it will be downward grafting of the chin rather than advancement, because the chin would be prominent most of these cases, not this case, but most of the cases of low angle deformities. So we did a mandibular advancement and did a chin down graft rather than a proper chin advancement. Similarly, another patient who is now on the other border, which is the high angle class 2 deformity. And this is pre-op and post-op, and the patient had a failure of the upper plate, so we had to remove this. And you can see that the bone healing has now taken place, and patient had a genioplasty done at the same time. Now in this patient, this is one of our few patients in which we treated the mandible first, because we needed to do what we call a counterclockwise movement, which is basically that you alter the occlusal plane. So this was the first case in which I was able to convince my to-go orthodontist, Dr. Afif Umarzia, to actually make a splint which is on the mandible first rather than on the maxilla first. So you can see that there is a straightening of the occlusal plane here now, and we caused and interestingly, if you look at the maxilla, you might think that the maxilla is normal, but the maxilla wasn't really normal, so we had to do a maxillary advancement also at the same time. So this was more maxilla and more mandible, but also some of the maxilla had to come forward because it would not allow us an overjet. This is again pre-op and post-op, and you can see that the patient had a more defined jawline and is a young patient, so he can't have a double chin right at this age. So he might put on 30 kgs more later on and develop a double chin later, but at this age he can't afford to have a double chin. Similarly, another patient in which we did a maxillomandibular advancement for a high angle case, as you can see here. So we did a maxillary impaction, but we also brought the maxilla forward. So if you do not have an allowance to take the mandible forward, you need to think about doing some advancement of the maxilla also, so that it allows you the cushion to bring the mandible more forward. And this is again pre-op and post-op. Now this patient was interesting because the patient came to us with the complaint of कि मेरे दांत बहुत ज़्यादा नज़र आते हैं और जब मैं smile करती हूँ तो मेरे दांत बहुत ज़्यादा और भी ज़्यादा नज़र आना शुरू हो जाते हैं. But as you look closely, there is a vertical maxillary excess, but the upper lip is also short. So you would need to do an impaction of the maxilla, but you would not want to do a large maxillary impaction, because that would really squish the face, and you can't have this. So if you have to err, you will have to err on the lower side. You can't impact the maxilla too much. So anyway, we did this was a large point B movement as we go to the lateral profile. So overall, if you can imagine, we were able to do a point B advancement of about 24 millimeters. और वो किस तरह? So we did a 6 millimeters of maxillary impaction, and we suppose that there would have been about a 3 millimeter of mandibular, 3 or 4 millimeters of mandibular point B advancement because of this. And then we did a 12 millimeter of mandibular advancement, and then we did a further 6 millimeter of genioplasty. So a total, when we were calculating it, it was coming to about 23 or 24 millimeters. But then we were able to improve the facial profile, and we didn't end up squishing the mid-face. We didn't take the maxilla too upwards. Similarly, another patient in which we brought the maxilla forward, but we also did something which is lengthening of the chin and a little transverse narrowing of the chin. Now there is a lot of talk on the V-line surgery, in which you typically do angular sections and you squeeze the chin and you elongate the chin at the same time a little. So this is, she obviously went back a little. She looks a little class 3 right now. This is an old patient, but just because of the large difference that we were able to create this. If I were to do it again, I would never do it single jaw. So most cases of class 3 patients, if you have to do one jaw, you really have to think about doing the maxilla only and not the mandible, because mandible alone for class 3 will almost always relapse. We'll be talking about this in more detail on our Monday workshop, that why would we want to do the maxilla more than the mandible. And Dr. Afif has a very nice, interesting theory about this, but we have stopped doing this. We don't do mandible alone unless it's a low angle class 2 patient in which we just have to bring forward the maxilla and the mandible and the maxilla is absolutely normal. A more optimal patient in which we were able to advance the maxilla and set back the mandible same time. Similarly, another large patient, large deformity with class 3, another patient, and when you do orthognathic surgery, you need to make sure that the end point occlusion is such that it sits well and there's good intercuspation. So most of the cases you need to have a class 1 canine relationship. So it does not really matter if you have a class 1 or a class 2 or a class 3 molar relationship. It does not really matter as long as it's a stable molar relationship, it's fine with us. Anyway, we were able to correct this, and this is pre-op, and the patient then had decompensations, and then this is the final result. Another beauty of orthognathic surgery is that you are able to see the immediate post-op result immediately at the end of the surgery, and then obviously swelling sets up, and then you're not able to do anything, you're not able to see anything, and we advise them not to look at the mirror for the first 3-4 days before the swelling starts to settle down. But you can see that immediately at the end of the surgery, and obviously then the mandible goes a little back to where it belonged. And this is him after a few weeks, after we begged him to keep shaving and lessen the swelling. So this is him pre-op and post-op with smiling, and you can see that with maxillary advancement, he is able to show more of his teeth in a more aesthetic way. Another philosophy that is now becoming more popular is to do the orthodontics earlier, do the surgery earlier, and then it does not mean that you don't do any orthodontics, does not mean you do suboptimal orthodontics, and I'm sure Dr. Fee would be showing some of the cases, and this is again the call of the orthodontist. If you think that you can manage the occlusion afterwards, I think you can be able to expedite the end result really well. You can quicken the whole pace of the treatment if you're able to do surgery first. So the overall name of this approach is called the surgery first accelerated orthodontics. Now the concept is that as soon as you are able to create corticotomies within the bone, the orthodontic movement, because of release of some hormones and the expression of some of the bone resorbing and bone depositing enzymes, the dental movements become extremely rapid. So this is him pre and post. And if you notice here that we were able to align this patient in less than 3 months after surgery. So what looked like a very large scale deformity, which would have taken probably 2 years of never-ending pre-surgical orthodontics, was corrected in 3 months after surgery. Not every case be done through this, and this is again pre and post-op. So even after the debonding, the patient displays a stable result. He shows most of his maxillary teeth that he wasn't able to show pre-operatively, and we were not able to. We didn't make the double chin too large. So this is again pre and post-op, a stable dental result and a nice aesthetic result otherwise.
So we have 5 minutes left, and I would request the audience to please maintain silence in the hall. At the back, please.
So the patient that I alluded to earlier in the day, and that this patient was being treated through an orthodontic camouflage, which means that the patient had a class 3 relationship, and the teeth were almost bordering each other. There was a -1 millimeter overjet, and the teeth were, kind of taken more forward to compensate and just to create an overjet. And obviously it was causing a compromise in the facial aesthetics. So Dr. Fief did a decompensation here, as you can see in the middle row, or is it called a column? It's the middle row. You can see that an overjet has now been created that we were able to correct later on with surgery. Similarly, another patient who was a complex patient because the patient required a maxillary impaction, a maxillary advancement, and a mandibular setback, nothing to the chin. So you can see that there was quite a large aesthetic improvement in this patient. Another patient with something done to the a two-piece maxilla, a mandibular setback, a chin advancement at the same time. So you need to think about the chin independently. So sometimes you have to, in a high angle class 3 patient, you would be taking the mandible backwards, but you would be bringing the chin forward. So this is what was done in this case. Coming on to wrapping up the presentation, coming on to cleft patients in which we have almost stopped doing orthodontic surgery, and we almost always would like to use distraction osteogenesis, in which we try to not touch the mandible, because the mandible is normal in most of the cases. There's a semblance that the mandible is large, but the mandible is not large. It's the maxilla which is small, and it is then evidenced as you bring the maxilla forward. Only with distraction you see that the mandible starts to look very normal. Similarly, another patient in which we had to do a double jaw even after a distraction initially, but the deformity was large, and we were able to correct this by a combination of distraction osteogenesis and orthodontic surgery. Now again, another patient in which you can see the amount of bone that we were able to create through intra-arch distraction, and then the patient had failing teeth, so we didn't have enough soft tissue to do any bone grafting there. So sent it to a good friend, Dr. Tariq Ali Khan, who added a little free gingival graft, and then he came back. We did bone grafting to cover the bone graft, and then there was obliteration of the facial of the labial vestibule. So he did another free gingival graft and a connective tissue graft. So after all of this, we were able to place 2 implants on what were earlier failing teeth. And you can see that we were able to provide a reasonable aesthetic result to the patient by doing some restorative work at the end. Similarly, another patient who had an iatrogenic loss of the premaxilla in a case of bilateral cleft lip and palate. And you can see that there's no premaxilla really at the time of alveolar cleft repair. The patient had distraction, and so we did distract in such a way that the teeth, the canines came close to each other, and then we did a bone graft, and it was an easier bone graft because there was no oronasal fistula. So the canines came in place of the central incisors, and then we distalized the posterior, mesialized the posterior dentition, and this is how she looked like afterwards from a large gaping defect here. If you look at the x-ray, you can see that the canines are now abutting against each other, and there's a little bone graft, and obviously it does not take up very well in patients who are adults now. And we were able to graft on the left side on the gap, and we were able to mesialize the molars on the right side, and there was again a reasonable occlusal result. We didn't do any setback of the mandible, but we advanced the chin because the chin looked small. So if you look here, so the chin advancement actually made a little nice aesthetic difference. We also did a coronectomy on this patient. There's another something that you need to follow in your practices. Patients who have deeply impacted third molars, in which there is a large risk of nerve injury, you need to just cut the crowns. And I tend to use pulpectomy at the same time, but you can do it without it. There's literature on both sides of doing a pulpectomy or not doing a pulpectomy. But you can see that after about a year or so of that initial coronectomy, the roots have generally migrated, and if they become symptomatic, you remove them. Otherwise, you can just let them be. I'm just finishing here. So patient with unilateral TMJ ankylosis, a one-stop shop taught to us by our boss and mentor, Dr. Adnan Shah, in which you open up the mouth, but also do a facial correction at the same time by increasing the length of the ramus on the left side in this case, and nothing to the chin, but a little onlay bone grafting on the right side. And this is the patient about 5 years after surgery, still able to open the mouth and does not have the remarkable facial asymmetry that the patient had. If it's an adult and it's within your orthodontic means, you can do a one-time surgery, which is correction through regular BSSO. But if it's a larger deformity, such as this, in a case of facial asymmetry, you need to do, we did a distraction first and then we did a double jaw surgery. So you need to do whatever you have to. I mean, you can't be critiqued on that you took many procedures and reaching to this level, I mean, to this stage. of facial aesthetics as long as you're able to show the end result as something nice. Similarly, another patient with distraction. And this patient had, if you look at the airway here, you can see that there's an improvement from about 6 millimeters of posterior airway space to close to 18 or 20 millimeters of posterior airway space. So the patient had severe sleep apnea, middle-aged patient. Last patient, and patient had bird face deformity. So we did distraction first, and then we did a genioplasty, and then even then the chin wasn't too remarkably forward, so we did a silicone implant on top of the genioplasty. But this brought us to the final result, and you can see that there's a considerable improvement here now. And this is a picture that he sends. I mean, I really begged him not to have a beard because, I mean, otherwise our result would not show on his face. But then he came from Bahalpur where he said that we'll have to keep this. So, summarizing is that the orthodontic surgical procedures are almost carpentry. You just need to become reasonably skilled to be doing it, and it's no rocket science at all. The key is planning, and similar patients with similar orthodontic readings would have different results. So there are many things that would come to you with practice, but you need to concentrate the most on planning. You always need to think double jaw. You try not to limit yourself by doing a single jaw procedure where you have to do a double jaw procedure. You never try to do this. So with orthodontic surgery, aided with good orthodontics, you're able to not only improve aesthetics, but also function in terms of respiration, in terms of occlusion, in terms of stability of your results. If you try to correct what is inherently a skeletal deformity by doing orthodontics alone, you would end up with patients who will be unstable and will have a compromised aesthetic and functional result. So thank you very much. Thank you.
Thank you so much, sir.
To deliver today's next lecture on diagnosis of bruxism in adults, a systemic review, I would like to invite Professor Hina Zafar. She is Professor of Prosthodontics, Institute of Dentistry, CMH, Lahore Medical College.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. I would like to take this opportunity to deeply thank the organizers for arranging such a magnanimous event, especially Professor Dr. Amir Mahmood Bhatt and Dr. Feroz, who have been really kind with us to invite us here and given us the opportunity to to address the audience. Pointer नहीं? अच्छा. चलिए. The topic that I have chosen today for today's lecture, I hope I'm not able to bore you with this topic because lately we have been really impressed by the two presentations of such a renowned speakers who have shown you real lifetime cases, and that has been really impressive. Thank you so much, Dr. Adnan and Dr. Nasir. The topic that I have chosen is quite pertinent to what we see in clinics very regularly, and that is a condition which has affected almost most of the population in the present day. And I think that it is the right time and the right moment to intervene and identify those specific cases which might get ignored or might get maltreated. And they don't get the desired treatment and the condition deteriorates. For that purpose, we need to identify the cases who are suffering from bruxism. A little bit of background that how and why does this bruxism happen and why do people tend to experience it. It can be because of many factors, but what I see nowadays, the leading cause of bruxism is the stress, the emotional stress that the patient has to go through. When I say that the patient is going through the stress, I need to stress upon that the main initiating or the main etiological factor is because of this stress, and the stress affects the neurological system. So it's a centrally mediated disease. We do need to understand that. Why do I stress that? Because when we realize that it's a centrally mediated disease, we would like to think before intervening into the occlusion. You don't give occlusal changes, you don't create occlusal changes before identifying the real cause and before diagnosing the condition thoroughly. Otherwise, the patient is going to have irreversible change in his occlusion and he's going to be affected throughout his lifetime. So these are the causes. The other causes can be anger, frustration, any underlying disease, any drugs. So they're different primary as well as secondary causes which can lead to this condition. And what happens after that? There can be different effects of this bruxism. We can have bone dentition, we can have TMD's effects, we can have effects on the stomatognathic system. I mean, a number of things that you can identify, but what we need to realize is to identify them at the earlier stage so that the patient does not have to go through and does not have to suffer a lot. So in fact, this was the thing that helped me to lead to this systematic review. I had a team of researchers with me which were really kind because it was quite an extensive job to look through the literature, to identify the appropriate ways to identify this condition and to understand the role of those diagnostic aids which are readily available to us within our country. When we are talking about bruxism, we need to identify that what are the types. As I told you earlier, the primary and the secondary. Secondary can be because of any other known cause. But what it does is it affects the nervous system, especially the parasympathetic nervous system, which leads to its inhibition and then its subsequent effect on the respiration, on the cardiac activity, and on the rest of the musculature, because of the release of the cortisol hormone, and then it has further deteriorating effects that we need to identify. The only good thing that the bruxism does to your mandible is to bring it forwards because of constant thrusting and bracing effects, and that says, supposedly, that it helps in patients of sleep apnea because the mandible is being brought forwards. Now, if we try to study bruxism, we need to understand that people do have this habit during sleep as well as during wake time. So we need to identify those patients who are only having sleep bruxism, and we need to identify those patients who are having sleep as well as awake bruxism so that you can intervene accordingly. There have been multiple attempts in order to diagnose it, in order to give a confirmatory diagnosis. There was one diagnosis that came up with from the American Association of Sleep Bruxism Criteria. And these were the conditions which said, which can be, according to them, they said that if the person is having at least 2 of these presentations, he might be a possible cause of bruxism. But again, this diagnostic criteria was also not confirmatory. It was also not validated by different studies. But at least it gives you a little bit of idea that what are the things that you need to look for. That you need to look for the tooth grinding, you need to look for the worn facets, headaches in the temporal region, the fatigue in the mandibular musculature, locked jaw, dental hypersensitivity, or hypertrophy of the masticatory musculature. When we look at the literature about the prevalence, although we do see many patients in our practice, But the documented evidence for prevalence of bruxism is almost 31.4%, and it is said that it is more common in women and people belonging to high socioeconomic status. But since this study has been done in Dutch population, you never know that these conditions might differ when we compare it within our local population. So that needs to be explored. However, the documented evidence is that it is prevalent in 31.5% of the population. Now coming to the diagnostic aids that we have, that the aids can be divided into instrumental and non-instrumental. Also, I would say rather that even this categorization is not absolutely right, because when we look at on the research methodologies, even the questionnaires are also an instruments, you know, they are also an instrument to assess something. So anyways, over here, the instrumental and non-instrumental discrimination is based upon the physical, physiomechanical device. If it is there, it is supposed to be called as instrumental. But if you are taking help of only clinical examination or questionnaires, then it would be called as non-instrumental tool. So non-instrumental tools are self-reporting. The patient reports by himself, history of the patient, and the clinical diagnosis. And the instruments can be different devices that I'll just go through with them. Intraoral appliances, electromyographic reading, and polysomnography, which is the gold standard. So just look at this clinical picture. A patient came to us, and with this clinical picture, we diagnosed him to be as a known bruxist. Just, I want you to have, if you are able to take this message back home, then you will be able to identify such patients in your OPD regularly. What you need to see here is, look at the occlusal pattern, look at the surfaces. It's a combination loss of erosive as well as attrition facets that are there. Look at the occlusal plane. Look at the formation of the occlusal plane. It's not regular. We have less space posteriorly as compared to interiorly. And then look at the bite. And I've not put that picture of lateral excursions over here. There was no guidance at all. The lateral guidance, the canine guidance, it wasn't there. So the whole surfaces, they have been treated, and all teeth were coming in contact during mandibular excursive movements. So we need to look at these things when we are examining patients, no matter for what purpose the patient has come to you. This patient reported to us for hypersensitivity, but this is what we found from the patient, that he is suffering from a major cause. So we need to identify these causes. Other things, if it progresses, it can lead to cracked tooth syndrome. That's visible here. I'm sorry I don't have a pointer over here, but you can see it in the top picture. These pictures are not from this particular patient, but I just put them there because I wanted you to have a look at other clinical findings. You can have buttressing of bone, you can have scallop tongue borders, and you can have some condensation of the bone that would be visible within radiographs in response to the excessive occlusal forces that are there. And of course, the facets would be worn. So another attempt of classifying this condition came from Lubezo et al., and he tried to classify it as possible, probable, and definitive bruxism. But by possible, he meant that if the patient reports by himself, or only you could find it as on a clinical examination that the patient might be suffering from possible bruxism. Probable would be the patient is reporting as well as there is some clinical finding, combining the two non-instrumental tools together. And then definitive would be that yes, the patient is having non-instrumental finding as well as combining it with the results of some instrumental results too, results from different devices too. So that will lead to some definitive diagnosis. But then again, in literature, this definition or this classification was also not accepted well, because people thought that it's a way of stacking up the diagnosis and you may not reach the confirmatory diagnosis. So this definition is also, this classification is also there, but this system has also not been validated, but you need to know these systems. Now, if we look at the non-instrumental tools, there are different questionnaires that are available. There are some questionnaires which are validated, which is very important for all of us to realize that we need to look for only validated and reliable questionnaires. And then other tools were self-reporting. The patient would report itself. And an additional thing that you can do, being a clinician, is that you can evaluate the patient get him or her evaluated by one of your associates in your clinical practice for the anxiety level, for anxiety level on different stress scales that are available. One of the scales that I have put in here, there are more scales too. You can just have a background. The patient might be concealing some information about his or her emotional status. You can evaluate them on this scale because these are the tools which are validated and they can give you a fair idea what the patient is going through. So that will be add-on. Now we come to the instrumental approaches. There are different devices that are available. One of them is Bruxoff device, which is quite popular. I hope that many of us are familiar with the term Holter monitor. Some of you might have some elderly patients in your homes might be going through the Holter's test. So it's quite similar to that, but unfortunately, we being dentists are not much familiar with this device because it is not readily available in the local market. This device works with the same mechanism. It is attached, strapped to the patient. The patient goes back home, sleep with this put on with his body. The whole readings of his musculature are recorded within the chip that is inserted into the instrument, and the next day the data is being realized. It's being analyzed, and then the patient is considered or analyzed that whether he does bruxing or clenching or thrusting at home or no. Another device which is available, which is presented in the literature, is bite strip, in which a strip is attached onto the side of the mandible, and then again there is a small little light that is, that is kept on, and that keeps on blinking, and the patient puts on these strips, attaches it to the side of the mandible, and then sleeps over it, so that all the movements of the musculature and the bite are again recorded in the chip, which is inserted in the topmost portion, and then it can be analyzed afterwards just to see that the patient does the bruxing habit or no. Then we have another device which is known as a Brux checker. The Brux checker, what does it do? It is again just like a covering, a tray that we normally give to the patient for making of the occlusal guard or night splines, and it is coated with the material. This tray is made with the foil and coated with the material, and we ask the patient to wear this device. Then the patient sleeps over it again, and then afterwards, how do you analyze it? You analyze it when the imprints of that coating, it goes away. So this will tell you the extent of the occlusal contact he has, or the way it happens during his sleep. Then we have electromyography test. I'm sure you are very familiar with the EMGs. It is especially people who are interested in sports, because many athletes, they go through these tests. So the same test can be utilized with masticatory musculature. And then we come to the gold standard, which is polysomnography. It is really good. It has been confirmed multiple times that yes, it does diagnose bruxism. But what are the, what do you call it? Why we cannot readily apply it here in Pakistan? Because the sleep labs are not very common. Plus, if you would imagine yourself sleeping in a sleep lab, what will happen? Would you be comfortable in the first night? So it has been documented in the literature that at least you need to spend 5 to 6 nights in a sleep lab, and only then the patient would be able to give you some reliable and valid results, which would be covering all aspects of the physical condition if the patient is a known bruxer. But what I mean to say is that the sleep lab or the sleep study is able to record the cardiac activity, it is able to record the respiratory activity, it is able to record the grinding noises as well, the patient's physical movements during sleep, as well as the occlusal contacts. So this is how the confirmatory diagnosis of bruxism is possible if you make the patient sleep in the sleep lab for 5 to 6 nights. So that is a thing which is there, but which is not very feasible. So we need to think that what we can do with these patients who come to us regularly. The aim of this systematic review is to evaluate and critically appraise the evidence that are the non-instrumental tools, because that is which is readily available, are good enough to identify the patients who are doing this bruxing habit, who are doing this parafunctional habit. If we look at the research question that we had for our systematic review was that again, the non-instrumental tools are sufficient for confirmatory diagnosis. We went with the adults. The intervention was again diagnostic tool. This is a PICO analysis that we are supposed to do when we are doing a systematic review, and we were comparing the non-instrumental tools with the instrumental ones and looking at the results of the intervention. The keywords that were used for this research study were bruxism diagnosis, bruxism analysis, and sleep bruxism, and we looked at these search engines and this much literature to analyze the data that has been available, the literature that has been available. Inclusion criteria is very important if you're planning a systematic review, because we need to see that what you are looking at or what you are taking hold of is good enough, it is of good quality. So we need to look at the clinical trials, the cohort studies, the cross-sectional studies, and case control studies, good quality systematic reviews. Only then you can take them as a confirmatory word. Then we need to analyze all those studies with 4 biases. The selection bias, this means the studies which you are looking at, they have included the patients according to the random method, selection method. Then we need to look at the performance bias, that the methods that are being used, they are good enough or good quality. You need to look at the detection bias, that the diagnostic aid that has been utilized is of good quality, and also look at the attrition bias, that how many dropouts were there from those studies, so that the data that you are looking at is giving you good enough results which are applicable to general population or not. So this was this is a brief overview of how many studies with which we started at. We just look at the sample size, it was more than 3,000, and we ended up in having only 8 studies which were, ruled out, that they were of that sufficient quality that can give us some reliable results. Now, if you look at the results, I hope you will not be bored with this much literature insight. But I will just, try to summarize them in a manner in which you are able to understand them amicably. So there was this one study which stated that what is the influence of motion and posture of the head on the data. And what they used in this study was a cordless ultra-miniature bruxism measurement device, in which a cordless device was attached onto the side of the patient. But in this study, they did not took the bruxis, known bruxis. They took only normal healthy adults. So again, the results of this study has to be reconfirmed on the patients who are known bruxis. So this study say that if the cordless device is kept away from more than 100 centimeter from the patient's oral cavity, then the results might get affected. So this means that you need to make sure that the cordless device as well as the device that is placed on the patient's mandible, they need to kept closer to have reliable results. How many minutes? 5 minutes. 5 minutes, okay. Then the next study was utilized the, again, another analyzer detector, EMG detector, in which what they tried to do was they analyzed that the patient might have first night effects, and but the fact that when they were asked to sleep in a sleep lab. So in order to eliminate that effect, the patients need to sleep within the lab for at least 5 to 6 nights to come to a conclusive diagnosis. Then another study showed or reflected that how do you analyze the patients who report to you with daytime clenching, the wake bruxism, and nighttime clenching. And according to this study, that the duration and intensity of EMG activity can be used to discriminate the functional and the parafunctional activities. And in this study, the good thing was they looked at the patients who were self-reporting, who came to them by themselves that they are going through the bruxism habits. Then we had another study in which the patient, they tried to analyze the effect of bruxism in patients who were self-reporting and as well as the patients who were clinically analyzed. And these were those patients who were having the TMD problems. And according to this study, that there was a strong correlation was found in this report if the bruxism is reported by a sleep partner. So if a sleep partner can identify the patient that he has some grinding habit, then there's a greater possibility that the patient would go through this, would be going through this habit. Then this study that I'm just mentioning here, it's a polysomnographic study, and it looked at the prevalence of bruxism in a larger sample size. They started from a good number of at least more than 1,000 patients, and they tried to first take the history of that specific patient, and then they analyzed them with EMG studies. And then they found out that if you look at their records, the important finding from their results was that if the patient, those known bruxists would have more insomnia, they would have more tendency to wake up after sleep. So that again gives you an indication that such patients who have insomnia would be known bruxists. Then there was another study in which they tried to look at the prevalence of bruxism, and in this study they tried to take hold of the questionnaires. They utilized different questionnaires, and what they analyzed was that the patients who are relatively obese, or the patients who have higher educational status, they are more prone to have these habits because of their sensitivity to their surroundings. Then there was another study in which they did a systematic review of different studies which were conducted to assess these patients, and according to this systematic review, they tried to analyze different devices, and what we found out from this study was that even the device that has been used, they were having different values. They were not having unanimous values. So even this systematic review also states that the studies that are mentioned in the literature are not good enough and are not that reliable that you can completely depend upon them to come to a conclusive evidence. The only good finding from these studies was that if the patient reports with fatigue or headache, that only then there is a greater chance that the patient would be having some bruxism. Then we move on to another study in which they utilized Brux checker, and what they found out that if the person is analyzed with a Brux checker, only then you can categorize the person that he would be having bruxism is that he would be having more anterior to posterior contacts. So this will give you a fair idea from anterior incisors to posterior molars. It would be having more contact. So if the person is having such contacts, there is a greater possibility that the patient would be having bruxism. So if you look at all these studies that came into the criteria of our systematic review, first we saw that out of those 8 studies, 2 studies did not even consider the non-instrumental tools. They only considered the instrumental tool. So again, that is also a thing for us to look at, to do more research, because if the non-instrumental tools are not being considered, are not being involved, this means that they can have a good role, but there might not be that sufficient evidence in the literature that you can analyze them. So while looking at all of this criteria, we can easily say that it may be a good practice to correlate instrumental recordings with the clinical findings. It is important for you to at least take hold of those non-instrumental tools like questionnaires, like clinical examination tips that I have just mentioned here. And again, you cannot say by confirmation that the person who reports to you with this bruxing habit would be going through the active bruxing activity in the present time. But still, it will give you a lead to the confirmatory diagnosis of that particular patient. There's not enough evidence that non-instrumental tools or questionnaires can be utilized alone in the diagnosis of bruxism. You need to look at certain devices for confirmatory diagnosis of bruxism. This is a place where we work in CMH Lahore Medical College Institute of Dentistry, and thank you all for your patient listening.
Dr. Hina, it is so informative, and I think the postgraduate students must have enjoyed it. And instead of just showing our own work, we should be more in the PPA conferences, should be more organized for the literatures. And in literature review, I wanted to ask you about the correlation of the bruxism and the TMJ problem.
And TMJ
about
problem.
the studies.
Absolutely. Thank you very much, sir. We need to understand, as I've mentioned over here, that the bruxism itself is a centrally mediated disease. Well, this is the first thing that we need to realize. And then this is a condition which starts from here, and the effects of this condition, they are transmitted to different organs of the body. The organ that we are working upon involves the whole of the stomatognathic system. It can be teeth, it would be oral cavity, it would be the TMD and the masticatory musculature. So this is the first thing that you need to understand. The consequence can lead in any direction, depending upon which portion of that system in that particular patient is weak. I hope I'm able to make you understand this much. So when we move ahead, we can say that in some patients, there would be temporomandibular joint that would be affected. In some patients, the occlusion or the teeth would be affected. In some patients, the masticatory musculature would come up with some pain in the masticatory musculature. Yes, sir, I've mentioned. Yes, I've mentioned. One of the studies, they did include those patients who were suffering from TMDs as well. I think it was second or third study. So it is important, but the thing is that what we normally see is in general dental practice that the patient, all the dentists do, they grind those teeth. Teeth are not to be grinded first. First you need to identify the cause. Then you are going to intervene, and then intervene with an irreversible manner, not a reversible, in a reversible manner, not an irreversible manner. And by what do I mean by that? We have splints, we have composite restorations, what we need to do is, instead of going to crowning the whole of the situation by just looking at the teeth and if there are facets there, don't do that. Please identify the cause and then go ahead with your treatment.
Dr. here you mentioned the effects of the bruxism on the TM joint. When the bruxism affects on the TM joint, is there any displacement of the meniscus or disc displacement?
So if I would like to categorize the temporomandibular disorders, there are two. One without internal derangement, the second ones are with internal derangement. When I say internal derangement, there is disc that is involved. And then within that internal derangement, there is a reversible pattern and then there is an irreversible pattern. By reversible, it is something which is good. I am telling all the postgraduates, reversible means something, as I have mentioned in the treatment as well, something which you can go back with. You have something which is still lying there for you. And irreversible, you are gone beyond that point in which you cannot do much, right? So if you are absolutely right, the disc does get affected and it gets displaced if there is constant stress on it. It gets displaced anteriorly. In reversible condition, the disc also gets engaged again, and then you can take it back in its original position by the help of different reversible means by splints, or by protecting it again by different kind of splints. You can easily, I mean to say stabilization splint and anterior repositioning splint. But irreversible means that the disc is permanently displaced, and then you need to take help of your colleagues from oral maxillofacial surgery that we need to do something about it. And yes, you have to relieve that area by opening the mouth a little more so that less pressure is exerted on the temporomandibular joint.
Yes, when there is a displacement of the TMJ disc, we will do the meniscopexy.
I think you might be absolutely right, but before doing anything of such kind, I think the better way is to be conservative. First you will identify the extent of the damage and then you can intervene accordingly.
First, we will try the splint
Yes, absolutely
yes,
right.
yes.
At least try the splint.
Okay, okay, thank you.
Thank you.
Thank you very much. If you have any more questions with Dr. Hena regarding this lecture, you can meet her personally afterwards. Thank you very much. We are running very late on the session.
Thank you, madam, for your befitting words.
To deliver today's next lecture on digitalization, a way forward in maxillofacial prosthodontics, I would like to invite Professor Muhammad Ali Chughtai. He is HOD Prosthodontics, Vice Principal, Sardar Begum Dental College, Peshawar.
Bismillahirrahmanirrahim. Before proceeding ahead, I would like to appreciate particularly the organizing committee of this today's conference. I would like to name particularly Professor Amir Bhatt, in addition Dr. Rizwan Mehman, as well as Dr. Feroz for organizing such an academic and healthy activity. Today, my topic for discussion is digitalization, which I consider a way forward in maxillofacial prosthodontics.
Can we please have, excuse me, sir, can we have silence at the back, please? Excuse me. Can we please have silence at the back?
Okay. Primary objective before me to discuss today this topic with you guys is primarily not only to highlight the role of digitalization in maxillofacial prosthodontics, but it is in twofold to share ideas as well as our experiences in relation to the digitalization, particularly its adaptation in our limited resources. Okay? For instance, I would be discussing today ear prosthesis fabrication. In addition to that, nasoalveolar molding and zygomos-supported obturator appliance, and last would be discussing patient-specific implants. Would like to pause for a minute so that you can able to see this presentation view as well. Ji, please. Sorry for this pause. I would like to show you the slideshow as well. Duplicate करो ना यार. वो चीज़ नहीं आ रही इधर जो slide next वाली. चलो ठीक है. ये. अभी ठीक है. चलिए ठीक है. Okay. Recent innovations in technology we admire that have generated a variety of techniques which has provided ample opportunity to change the procedural steps what we are doing today. Let's have a glance over the traditional pathway which we used to follow in any prosthesis fabrication. In a traditional way, we actually proceed straight away with an impressions with either using hydrochlads or silicons, and then to pour a cast and ultimately proceed step-by-step fashion. And in last, we get a plies from the lab after a manual finishing. However, if we compare it up with the digital, so the workflow is reasonably simple. Let me elaborate it further here. All that we need is we can substitute our conventional impression with an optical probe impression. Or if let's suppose we don't have, for instance, optical probe, still we can take an impression, we can pour a cast, and then to do laser scanning. Even in today, different softwares are available. We can straight away scan our impression. All what we get, STL file, upon which we can proceed ahead for designing. And then for its execution, we even do have such type of silicon 3D printing devices as well. Internationally, in developed countries, they are utilizing it up. Okay. Let's suppose if we don't have that, still another option is that we can make use of rapid prototyping equipment, or in certain situations, we can make use of CAD/CAM technology as well. Today, we'll be sharing with you how in our department at Sardar Begum Dental College, Peshawar, we are utilizing this digital technique within our limited resources. Foremost, we'll be sharing our ear prosthesis fabrication through a digital technique. Last year, a young person of age 30 who lost his right ear in a burn injury referred to me by a well-known plastic surgeon in Peshawar. This time, instead of taking a malage impression, we straight away proceeded with we asked the patient to have a CBCT. We extracted soft tissues from the soft tissue window at CBCT, and ultimately, we exported this STL file to another software named PlastiCAD software. Right at the moment, I would like to appreciate Mr. Zulfikar Atiq, who run his own lab in Lahore. In fact, he provide a marvelous facilitation related to 3D printing technology. So, by the help of PlastiCAD software, we in fact cloned the model. Ultimately, we superimposed the left ear on the right side, and ultimately, you could see and appreciate how reasonable it is. It is reasonably good that we have restored the contours of the left, exactly the mirror image of the left ear. So, being a prosthodontist, this is not really easy task to proceed for or to sculpture it in such a way that it should exactly look like the adjacent or opposite or corresponding ear. Okay. Then the next step was 3D printing of the right ear, which was exactly the replica of his actual or left intact ear. This is the 3D model made up in polylactic acid. This is how nice it is, adapted at the model. And this is what we are evaluating, we are seeing or doing trial on the patient face. You could appreciate the lateral view, and then this is the frontal view of ear prosthesis. A reasonable adjustment or reasonable shape we could achieve at this stage. Now, this is the point in which we hybridize this digital technology because we were not having a silicon printer. So how to execute exactly to full extent. As I said earlier, would like to show how we can adopt this digital model in our limited practices. So what I did, I took this impression, or I took a duplicate of this polylactic acid based 3D printed ear in wax, and then we proceeded in a conventional way of flasking, dewaxing, and packing. Then I'm doing this silicone mixing. Presently, we are using Technovent M511 kit of skin silicone for the fabrication of ear prosthesis. And this is what we are doing, skin matching. And then, as I said earlier, it's a point of hybridization. I called it a hybrid model, a blend of digital technology with our conventional technique. So this is what packing I'm doing. And ultimately, this is what the ear we received immediate after, after curing of ear prosthesis. You could appreciate there is a need of extrinsic stain. And this is what extrinsic staining we added, and ultimately we get that ear adhered to the site with the help of medical adhesive. This is what the pre-op and what we achieve post-operatively at the end of whole procedure. A reasonable ear prosthesis fabricated and executed, and you could appreciate the smiling face of the patient by having such a reasonable prosthesis, although I can't consider it ideal, but to maximum extent we could achieve. Right at the moment, if I could have this 3D printing technology as well, particularly for this I need 3D printer, silicon-based 3D printing device. So we can execute the same, rather than doing conventional technique for flasking and packing, we can straight away get a base colored ear printed straight away through this 3D printing technology. Okay. But as far as it was not available in our region, in Pakistan, this silicon printer was not available. So we patch it up, we blend it up with our conventional technique. Now, would like to move to another prosthesis, which is nasoalveolar molding. Since last 10 years, our Department of Prosthodontics at Sardar Begum Dental College is providing facilitation to the cleft lip and palate babies, and we are proceeding with a conventional technique for NAM appliance fabrication. Now, for that matter, a local plastic surgeon, Dr. Taimur, referred this kid to me in the Department of Prosthodontics for the fabrication or for alignment of nasoalveolar segment for this bilateral cleft lip palate baby of age 4 days. So this time again, we try to adapt a model for the, a digital model for the fabrication and execution of this NAM appliance prosthesis. So this is what we did. Ideally, we should have taken impression with an optical probe, but of course it was not available. So what we did, we preferred to move through the alternate path. And what was that? That was to take an impression in silicon, either to have it scan, do laser scanning, or to pour a cast and then do laser scanning and make a STL file for yourself. Based on that STL file, we can design a prosthesis. How? We'll let you know in a couple of minutes. Then the next step, as I said, virtual modification of the digital model. For the purpose, I would like to say that there are plenty of softwares available in today's global network. The foremost and most utilizable in Pakistan is ExoCAD. Then we can make use of this 3-shape mesh mixer in addition to that Geomagic Design X. Presently in our department, we are making use of this ExoCAD software, and so what we did for this patient as well. We did, the foremost step was arch segmentation into anterior premaxilla and posterior lateral segments, which we want to move towards each other so as to get it aligned. You could appreciate there is a space of about 9.3 millimeter on right, while 8.4 on the left. So, of course, I need in the first instance to move this premaxilla back and towards right so as to lower down the space, get it equal to the left, and then to move those corresponding segments towards back or towards the lateral posterior segments. Then the next step was, in addition to our segmentation, adaptation of this overall grid. By virtue of this grid, we can go stepwise, step by step, a millimeter towards posterior lateral segment, so that ultimate our aim is to get our premaxilla aligned with that so we can proceed ahead. So this is how we are doing at ExoCAD, 1 millimeter in each segment, and usually in NAM appliance fabrication and NAM appliance based treatment, we usually expect up to 1 millimeter at most movement towards the alveolar segment of premaxilla per week. So this is what we are doing. By the end of 4th week, this was achieved, 6.3, and then this is what the 5th week, 6th week, 7th week, and ultimately by the end of 8th week or 2 months or so, we were expecting to close this space. So based on this data, in fact, we decided to have series of 4 different appliances to be fabricated so as to use in a step-by-step fashion. This is what we did, virtual designing of the NAM appliance at one moment or at one go. And then step 4 was manufacturing of this NAM appliances by digital technique. Final design can then be or was then exported as an STL file to the manufacturing unit, which could either be 3D printing devices, or it could be rapid prototyping device, or at the same time it could be CAD/CAM system. In our department, we are utilizing at the moment CAD/CAM system for this. So what we did for the milling up of this appliance, we utilized CAD/CAM, and we milled the NAM appliance or nasoalveolar molding appliance by milling up from the polymethyl methacrylate disc. Now here, a question was in my mind whether, since so many years we are proceeding and providing services to our kids really based on conventional technique, whether this digital technique is better, although we have read a lot about in the books. But of course, being a research student, we must have a thrill to do or to evaluate, to assess it. So what I did, we fabricated another appliance for the same kid with a consent from his parent with a conventional technique. First, we installed this NAM appliance which was fabricated with a conventional technique in the baby mouth, and ultimately, later to that, we fabricated another appliance which was fabricated through a CAD/CAM technology. Believe me, this is what we have assessed, that ultimately a CAD/CAM based or digital technology based fabricated appliance was of more worst. Not by just saying, but because the data was preserved, all the procedure was rehearsed ahead before its execution. So this track was quite fast. But in addition to that, the marvelous point, or what I appreciate most, is that its appliance accuracy. It was reasonably good. Its adaptation was good. So of course there was less chairside time adjustment required for the patient. And this is what ultimately.
3 minutes left, sir.
Okay. Now this is what the nasal stent added in the NAM appliance once we left with 5 to 6 millimeter space in the alveolar segments. Now after this NAM appliance prosthesis, I would like to proceed with digitalization or adaptation of digitalization in zygomatic implant case. Okay. Here, he's a patient of age 35. He was referred last year to me by a maxillofacial surgeon, Dr. Zubair Durrani, who did surgery of maxillectomy, and this patient lost maxilla in maxillectomy procedure so as to save his life because of post-COVID osteomyelitis. So he was referred to me for a prosthesis fabrication. How could, being a prosthodontist, I made it anchored or made this obturator anchored or adhere in the oral cavity? There is nothing available, not a maxilla, not any tooth, which could be utilized for the sake of clasp addition. So ultimately we decided to have some anchoring appliance. So the only option or the main option available to us, or to some extent we finalized, was zygomatic implants. At this stage, I particularly say thanks to my colleague, my senior, as well as my friend, Dr. Adnan Aslam, for his valuable suggestions while designing this or identifying the potential space for zygoma implant. And for execution, Dr. Zubair Durrani, particularly, I would like to appraise as well as acknowledge his services, because he was the main person who executed the implant to be placed in the zygomatic arch. This is what the position we identify, and by virtue of CBCT, you could see we can better able to rehearse even. How can? By having a 3D printed model of the maxilla. Is it possible to have this maxilla in your hand before surgery? No, not at all. This is what CBCT based 3D image which have been utilized for 3D printing. And this is what ultimately we got the basic model of maxilla with proposed implant positions according to the prosthesis of our primary obturator, which got anchored in the mouth by the help of circumzygomatic wires. Okay, so based on that, we finalize its position. We finalize to have 35 millimeter implant at the anterior, while 45 millimeter at the posterior location. And this is what the surgical guide we print it up with the help of 3D printing applies. This is what we are doing rehearse again and again, just before, even before surgery, and this is what we disinfected the hole with the help of pyridine before to be utilized on the patient mouth. This is how we are proceeding guided surgery for implant placement in the zygoma location. Due to time constraint, would be going ahead straight away from the surgical aspect, would like to emphasize the prostho at the moment. So, but this is so very important that guided surgery is today's demand, and we must have to acknowledge the services of 3D printing technology as well as CAD/CAM in this situation, whosoever is providing. And this is what the CBCT immediate after placement of these 4 zygomatic implant. Now the next step, which is critically important from prosthodontic point of view, is the designing of bar, and to provide anchorage spaces or appliance so as to adhere your obturator appliance, which is quite heavy for the maxillectomy patient, I must say. So again, we utilize the technology of ExoCAD, and we are using this digital technology by virtue of this ExoCAD software. After identification of these scan bodies, we adapted the prosthesis image, which was laser scanned ultimately, to evaluate how much clearance do I have, and how can I make this bar reasonably positioned so as to distribute occlusal load. And this is what we are doing. The beauty of this 3D system is that we can able to identify in separate as well as to relocate this bar on the virtual cast, and then even with the opposing cast you can get able to know how much clearance do you have, and how much and what is your goal which you have identified beforehand with the help of appliance you have provided in the form of primary obturator, and what ultimate you want to achieve in terms of aesthetic demand of your patient. And this is what we are doing. Again, we adapted the patient cast, patient appliance image over it, superimpose it, and finalize the position, keeping in mind that ample space should be provided for the hygiene maintenance underneath these bars. And this is what it is. This is what the 3D printed model of the prosthesis or primary obturator, which was installed with the help of circumzygomatic wiring for the patient, and these are which is actually providing a guidance that how much aesthetic outcome I can improve ultimately. And these are the bars which are milled through a CAD/CAM technology. With the help of CAD/CAM, we milled this bar in wax first, then we place the precision attachment with the help of surveyor over these, and ultimately we milled it up, and this is what we are doing the trial. In the initial trial and placement, we are making care of this, that it should get anchored with the help of a floss, so that obviously there is no hindrance. The patient may swallow it if you slip it up. So this is very important to be in your mind. This is what the bar, we fixed it up with the help of 4 screws. These are multi-unit abutments. And ultimately prosthesis is ready with the locator attachments, and by virtue of locator attachment, we made it anchored or adhered in the oral cavity. Without these zygoma implants, in this situation, there was no other way available, being a prosthodontist which should I have used for anchoring up the prosthesis. And this is what the
Sir,
picture
we are really
of
getting short of time, please.
I would like to appreciate if 5 minutes more should be given to me. I would like to, so as a compensation, which had happened in the earlier, that problem of slideshow. Okay, pardon for this. This is a casual picture of me, myself, and a patient and a team of my PGs, ultimately at the very second follow-up visit of our patient. Now, is this only way to proceed with such type of situations of maxillectomy to get it adhere only through a zygoma implants? Of course not. I would like to appreciate first a friend of mine, Dr. John Nason. He belonged to Chennai. He's oral maxillofacial surgeon, and he's running his Center for Technology-Assisted Reconstructive Surgeries. I'd like to appreciate him for letting me permit to share his slides right at this auspicious forum, where many of seniors, in addition, a budding prosthodontist are sitting. I would like to pass on this phenomena, this concept to them as well. So the first case would like to explain is hemimaxillectomy done in this patient, middle-aged patient lost his left maxilla. What to do? These are many scans of this patient, right and left. You could appreciate there is no bone at all at the left side. What to do then? Either to place zygoma implants, again a nasty surgery, but at the other end, what could be the outcome? How will you distribute the occlusal load? That is a tricky job at the same time. So what he did, he ultimately first get this virtual cast, virtual designing, and ultimately he finalized to execute by the help of patient-specific subperiosteal implant for his patient. And ultimately, he decided to get it anchored with the help of these mini screws, depending upon different lengths. These are around about 15 screws he's utilizing for this whole appliance to get anchored into place. Okay, so leading to these 6 millimeter screw to be utilized in the lateral nasal bone. Then in the most notorious location of zygoma, he's using up to 10 millimeter, and in the distal lateral area, 8 millimeter screws he finalized. These are the mini head multi-unit abutments he is going to install ultimately, and then he printed this appliance with the help of a metal printer, 3D metal printer in titanium. And this is what he is executing his plan intraoperatively. You could appreciate this appliance ultimately in the patient mouth, and by virtue of this locator precision attachment, he is ultimately making it adhere in the patient mouth. And in this way, he's saying, I have transformed the life of a patient from a miserable condition of hemimaxillectomy to a reasonably smiling condition. A next case of mucormycosis, which has happened because of COVID. So post-COVID mucormycosis has led this patient lost his left maxilla again in partial maxillectomy situation. This is what had happened ultimately. You could appreciate the scan. And this is what the patient-specific implant design he finalized for this patient. And this is what how he executed ultimately by printing this appliance through the help of metal 3D printer in titanium. And this is how he ultimately utilized it and ultimately get it fixed. And you could see and appreciate the bump at the left side. If, let's suppose, I would have proceeded in this case being a reasonable prosthodontic experience, I won't be able to lift this bump only because of obturator appliance, which was not possible. All what had happened was because he provided the bone substitute in terms of metal obturating appliance or patient-specific subperiosteal zygomatic implants. So without his basic support from underneath his skin, of course, only by obturator it is not possible to get it aesthetically pleasing in the way he is presenting at the moment. So besides this, for a different tricky condition, he also shared these few designs. Here again, almost hemimaxillectomy, but a lot more moderate type of hemimaxillectomy, significant loss of bone and maxilla you are seeing, and we can appreciate how much significant this design would be for the patient. In other case, you could see and appreciate a reasonable design with multi-unit abutments for locator attachments to be attached later on. And now, this is a case of mine. A patient referred to me from interior Punjab, and again Dr. Zubair Durrani, he referred that patient to me for further progression with the obturating appliance. So ultimately I consulted John Nathan for this patient, and we decided to have it done with the help of subperiosteal patient-specific implant system. Although surgery is yet to be proceeded, so just at the moment we are showing this design. Okay, hopefully in near future, once we complete, we'll show the whole intraoperative procedure and share my own experience in upcoming next conference, inshallah.
Sir,
okay, these
are
are few
Sir,
designs.
your 5 minutes are up.
Okay, just one. Okay. And this is what the titanium frame supported prosthesis he executed and provided to one of his patients. So by showing these cases, I would like to open or would like to provide an opportunity, particularly for my budding prosthodontist sitting over here, that there is all what we need is to get ourselves acquainted with the latest technology, then sky would be limit. And this is the important step we must adapt, particularly the young prosthodontics. They must come forward towards this digitalization and adapt these procedures so as to provide or from the point of view of well-being of our community, a needy community. These are few many references. I particularly appreciate this book and would like to recommend to the budding prosthodontist. This is a current book written about restoration of facial defects with digital technology, a very nice and latest book available. I must appreciate if you could proceed to read it out and have a valuable output and provide your services to the needy community. Thank you very much for being patient. Listen, thank you very much. Any questions? Yeah, sure.
We have been doing the conventional way and now coming into the digital state. And I think this is a very good presentation.
Thank you.
There have been quite a few mucormycosis patients which I have also treated, like total maxillectomies and subtotal maxillectomies. Very difficult though, but was successful in doing so. My question is that you have just mentioned about one of your patients, and you had that designing done by Dr. John Neeson. Is he prepared to give us these titanium splints also, if we ask him, so that we can do the remaining procedure here?
Yes, ma'am. He has made this center, one in Chennai, India, and second in Dubai. We are in touch. I have shown this number as well. We'll pass on that number to you as well. Please. We can get that. One of another case, although due to limited time constraint I have not shown, again a maxillofacial surgeon in Peshawar referred that patient to me. That kid is having a Treacher-Collins syndrome, in which mid-facial defect is there. Of course, due to mid-facial defect, patient overall outlook is very much disturbing and disappointing from a growing kid point of view. So for that, I have also consulted him as well, and he proposed certain designs. We'll share later on, inshallah, with you in individual, ma'am. So for that, we have decided to fabricate zygoma first, to lift this bump here, we do surgeries, or if I could say biphasic surgery. In the very first phase, in earlier age of 11 to 14, we first lift this area and then place the zygoma here in the form of a zygomatic splint. Okay, and later on, once he grew up to the age of 18, a second phase of surgery would be required to lift up the mid-facial defect as well. So, in addition to that, ma'am, for your kind concern, in fact, would like to share, they are providing facilitation even in mandibular TMJ replacements as well. They are providing their services in titanium-based, milled as well as printed TMJ appliances as well. They are providing with the glenoid fossa as well as condyle. In addition to that, I would like to appreciate again here one of a very best, or if I could say a full of initiative potential person in Pakistan is Zulfikar Saab, Zulfikar Atiq, a very nice guy, a friend of mine. In addition to him, I must admire and appreciate Rashid Chughtai. Okay, at this particular forum. They both have imported metal printers. They both have imported metal printers, and most likely in upcoming next month, they will get it cleared from the customs as well as IB. So many intelligence clearances is required in a metal printer particularly. And they are taking start with such type of prosthesis, inshallah, in Pakistan. And the one with the Zulfikar is that printer dimension he was talking is such enough that we can print whole of mandible as well. The missing part of mandible could also be printable in that metal printer.
Zulfikar sir was, as a matter of fact, when we started the CBCT in Fatma Memorial, so we had employed, rather we hired him that he should help us out, and he has been doing it. Now he has moved out to the Dental Avenue, and there they've got the all this facility there. And I was just asking him last week that how can I make a complete denture there? And he said that they still have a problem with the setup of the teeth, because they do not have the material. But the material at the moment has too many fillers in it, and it is not suitable. And as regard this, he said that he still hasn't got that printer yet, the metal printer, but he has done all the other printing in PEEK, which is, and he's doing a lot more of the maxillofacial. For the oral surgeons, he's doing a lot of work.
Yeah, exactly.
But as regards these prostheses, it is still in the pipeline.
Yeah, exactly. These are in pipeline. And in fact, the one I've shown this patient who was referred to me related to, because of maxillectomy, he lost his whole maxilla, and ultimately we finalized to proceed this time. Rather than a zygoma implant, I must proceed with this subperiosteal patient-specific implant for this patient. So he is the person who provide us this facilitation, and ultimately we have consulted Dr. John Nason, and with the vision in mind that we should learn this technology as well, and ultimately we should do that printing in Pakistan. That would be much less costly and much less expensive, and make it affordable for our needing patients.
I will. The good news is that soon we are going to conduct some workshops on this digital CAD-CAM and all these printing materials. So they would be starting, and I'm sure that people will benefit from that.
Inshallah.
And the best thing is that, as you mentioned, Chughtai sir, the silicone material that he has, factor 4, I think that is the best one, because I've tried all the others, and I find that this is the best material, because it has less porosity and it is gives you a very smooth surface.
Yeah, exactly.
And when you're doing the pitching of it, it really helps and get rid of all the air bubbles in it.
Yes, ma'am.
So
I myself have ordered that, and I'm using currently extrinsic stains of factor 4. In fact, even the prosthesis provided recently to the patient of ear prosthesis, that was factor 4 based medical adhesive. I agree to you, it's reasonably more good as compared to the Technovent, in fact.
I know. The Technovent is a little...
Thank you, ma'am, for your nice comments.
Thank you very much. I think I really appreciate that.
Thank you, ma'am.
Do you have a question, sir? Dr. Naan ko de dein. Can this be the last
A
question,
very,
please?
very impressive presentation, very impressive cases. Now, this is just a curious question, and this is about if a patient with a very large oronasal fistula, such as all of the cases that you've shown, the prosthesis that you ultimately provide to them, would that be a fixed prosthesis or a fixed removal prosthesis? Because, I mean, you can make a removable one that the patient can take out in the evening. Otherwise, the food ingress from the back of it, and it's hard to actually have a very nice seal in a fixed prosthesis. If you indeed have provided them, all of them, with a fixed prosthesis on top of these zygomatic implants or PSIs, how often do you recall the patient, take the prosthesis off, have the service done, and then send it back?
Thank you very much, Dr. Adnan, for having such a nice question. That is very nice, in fact, and very pertinent question related to my presentation. I really appreciate, first of all. Second to that, there are twofold problems related to the provision of fixed prosthesis, particularly in the maxillectomy patients. Foremost is that what you mentioned, hygiene maintenance, whether patient could able to remove that, and as there is no nasal floor as well, so obviously that slough will come and ultimately make that area quite nasty. So this is the primary reason based on which I would prefer to have removable one in the form of a removable bridge having a hybrid prosthesis, okay? But in first fold, I appreciate that it should regularly be removed by patient. So that's why in my own case, so I prefer to have a locator attachments get installed so my patient could able to get it removed, get it cleaned under tap water each day, and then to place it oral cavity. So has to avoid certain mucosal sorenesses and different other problems we could expect. Second reason behind selection of this hybrid prosthesis or removable prosthesis is, that there is a lot of, due to loss of big chunk of maxilla or big chunk of bone in the form of maxillectomy, so obviously clearance would be more. From prosthodontic point of view, the appliance prosthesis height would appreciably be more than 15 millimeter. So for that matter, if we are providing with the fixed prosthesis, there is a separate phenomenon I would not like to go into detail that we named heat sink. That is a separate phenomena based on which obviously it's very difficult to have it veneered, the metal substructure get veneered with the porcelain straight away. So PFM type of prosthesis is again not possible in that unless and until we are using CAD/CAM technology and whole of the prosthesis being milled in zirconia. But again, two problems get appeared. First of all, that much big, for 15 millimeter length, we need to have at least 18 to 20 millimeter thick zirconia block, which is very much expensive. I don't think it is affordable for our patient. Okay, so it might be not less than $2,500 to $3,000 for just single block, and for one obturator we need that at least single block would be utilized. Second problem will be this much huge thickness and ultimate obturator, that would be too thick as well as too much heavy for these mini screws to get it anchored into its place. So if we even got them fractured, you know better that in multi-unit abutment, if even a single screw get fractured, it's a nightmare for prosthodontists, not only for prosthodontists, for maxillofacial surgeon at the same time. Okay, so from these perspectives, I would appreciate that we should proceed with the removable appliances, and that button of removal of that prosthesis should be with patient. Thank you very much. Thank you.
Thank you, sir.
Yeah. If we are extending that prosthesis up, of course, very well said by madam that hypernasality can easily be controlled.
Thank you, sir. Thank you very much.
Thank you, madam.
Rest of the questions can be done personally, please. We are already running about 40 minutes late.
Thank you so much, sir.
Now we would like to request the panel of experts to present souvenir to our respected speakers. I would like to request Professor Asif Ali Shah to please come forward and receive your souvenir.
I would like to request Professor Nasir Salim to please come forward and receive a souvenir. I would like to request Professor Nasir Salim to please stay on the stage and receive the souvenir on behalf of Professor Dr. Hina Zafar.
Now I would like to request Professor Adnan Aslam to please come forward and receive your souvenir.
Now I would like to request Professor Muhammad Ali Chukhtai to please come forward and receive his souvenir. This brings us to the end of the third scientific session, and now the time has arrived. Lunch will be served at 1:30 p.m. sharp, so you all are requested to be here in the hall by 2 p.m. for our next scientific session and concluding session.
Thank you so much all.